welcome to the National Colloquium on Maternal and Reproductive Health and the Law. And we're excited that finally we are here. Aren't you excited? It's one of those things we've all wanted to have. We are going to start and briefly use a few minutes to know who is in the room before we get into the gist of the day. At least we have all our speakers, and only two are not yet here, but they're on their way. Actually, they're in the lobby, so we can be able to start. I am Salome Nakawesi. I am an activist. I've been in the trenches of activism for the entire part of my life. And I'm excited to see like-minded actors here, and also those that are joining online. I'll be moderating today. Today we are going to have a conversation. Today we are going to learn, we are going to unlearn, we're going to share ideas, we're going to bring different sectors together, but also we are going to jointly strategize how do we move on from here, as well as celebrate ourselves. How much have we achieved, but also what are the pending gaps and challenges that we need to beef up. So I'd like to ask the person that is passing around the mic to move to the table. We are going to move from the back to the front. Please just tell us who you are, and then the space you're representing, or constituency you're representing, or the specific area of interest within the broader context of maternal and reproductive health and the law that you're here.
Thank you so much, moderator. I'm Joyce Najemba. I'm a registered midwife by professional, and I work with Mulago Specialized Women and Neonatal Hospital. So I'm here being delegated with one of my colleagues by the names of Namakura Rita. She's not around, so she delegated me to be here. Thank you so much.
Thank you too. You're welcome. Mulago is here.
Hello everyone. My name is Penny Nantumbe. I work with Vimos Creations.
You're welcome, Penny.
Penny.
Hello everyone. My name is Olivia Twijuche. I'm here on behalf of the Executive Director, Women with a Mission. We advocate for the rights of women in Mbale.
Okay. Welcome all the way from Mbale.
Good morning, everyone. Good afternoon, everyone.
Don't worry, some people it's morning because they're joining us virtually.
Yeah, you're the one who confused me a little bit, but I'm happy to see you, Salome. My name is Betty Chadondo. I am the Director of Family Health at the National Population Council, and I'm very, very happy to be here.
Welcome, Dr. Chadondo and the Council.
Good afternoon. My name is Anton Wesaka, and I'm a journalist. So whatever you're going to say, I'm going to note down. Thank you.
Okay. Positive reporting. You're welcome.
Good afternoon, everyone. My name is Anne Lumbasi. I work with the Center for Health, Human Rights and Development, and my interest around this is maternal health, really, in its broadest sense. Yeah.
Welcome, Anne.
Good afternoon, everyone. I'm by the name Kamagara Editor, and I work with the Alliance of Women Advocating for Change.
Welcome, Awak.
Yes, good afternoon, everyone. I'm Immaculate Omcha. I am Executive Director at Center for Women Justice Uganda.
Welcome, Immaculate.
Good afternoon, everyone. My name is Noor Nachibukamasi. I am the Deputy Executive Director at the Center for Health, Human Rights and Development.
Welcome, Sehad.
Good afternoon, everyone. My name is Lilian Navatans Nsubuga, and I am the Program Coordinator for Maternal Health at the Parliament of Uganda.
You're welcome, Lilian.
Good afternoon, everyone. I'm Nachuguda Presi from the Parliament of Uganda.
Welcome, Parliament of Uganda.
Good afternoon, colleagues. Dr. Robert Mutumba is my name, representing the Director Public Health, Ministry of Health.
Okay. Welcome, Dr. Mutumba.
Good afternoon, colleagues. My name is Olive Sentumbwe Mugisa. I work with WHO Reproductive Health.
Welcome, Dr. Olive.
Good afternoon. My name is Judith Adarach. I work at the Netherlands Embassy on sexual and reproductive health and rights. So everything there is of interest to me.
Welcome, Judith.
Yes, good afternoon, everyone. Baksh Asman from Planned Parenthood Global.
Okay, PPG is also here. Welcome.
Good afternoon, everyone. My name is Josephine Bebona Babungi. I'm the woman MP for Bundubujo District. I'm the chairperson Naumpa at Parliament. And I'm here and happy to share all about maternal health. Thank you.
Welcome, Naump and Honorable.
Good afternoon to you all. My name is Joseph Musingzi. Difficult how to describe her. I'm retired now and working as Senior Presidential Advisor on population issues.
Welcome, Dr. Musinguzi.
Good afternoon, everyone. My name is Moses Mulumba, and I work with Afya na Haki. I'm so happy to see you all. Thank you.
We can't welcome the host. I think it's you welcoming us.
Yes. Good afternoon, everyone. My name is Dr. Migade Deo Gracious. I'm a senior medical officer working in the Reproductive and Child Health Department at the Ministry of Health.
Welcome, Dr. Migade.
Good afternoon. I am OIS John Mary Vianney, and I work with the Reproductive and Child Health Department. Thank you.
You're welcome.
Good afternoon. Bruno Semwanga, Reproductive and Child Health Department, Ministry of Health.
Welcome. So, I think that's us for now. Why did we ask that we introduce ourselves? For us to get a feel of who is in the room, for us to connect with each other, for us to allow ourselves to know the broadness of the work we do, but also how we all contribute to a bigger conversation. And of course, this colloquium is aimed at really enabling us as partners to comprehend the role of courts in advancing maternal and reproductive health. Secondly, for us to track the efforts and progress made to see how far have we gone. And this is the progress by different actors, as well as ensuring that we are recommitting ourselves. What more do we need to do? Where are the gaps? We also expect that us as different stakeholders are equipped with the theoretical and practical knowledge about the concept of reproductive justice and its utility to the continent's efforts to realization of SRHR of its citizens. Of course, lastly, we have knowledge products. And like we say, we can't do this work without theorizing, without building a body of knowledge, but also without localizing knowledge on maternal and reproductive health from our lens as Africans, because that has power in it. So there are knowledge products that are going to be disseminated and launched today. And of course, what we expect out of this is policy recommendations. We also expect an enhanced awareness about the issues, but even also how we all contribute to those issues. We expect to collaborate and network. And of course, I saw some people noting down other people's names. And please feel free to connect and network. When you look at our program, we have a cocktail afterwards where we're going to continue the conversation. There's power in networking. That is the new future where we are located. And of course, lastly, we are here to generate knowledge and disseminate it. So without much ado, I'd like to welcome you and inform you that on your tables, you have a pen, you have a notebook, you have a program, but also more importantly, you have lovely people you've sat with. Feel free, settle in, feel at home, but also let's engage in the conversation. Let's do a lot of the learning that we need from each other. With that, I'd like to take the opportunity and the humility to invite the first speaker. Somebody that when I was young, I am now youngish, I do not know where I am, is somebody that we all knew that was very clear around reproductive health in Uganda and on the continent. I'd like to take the opportunity to invite those two people, but one will speak after the other. I'll invite Dr. Jotham Musinguzi to come and give us opening remarks. That is not enough. For a whole senior presidential advisor and somebody who has worked for decades setting the pace. You're welcome, Dr. Musinguzi.
Thank you, Sorome, and good afternoon once again, ladies and gentlemen. I hope technology will, I am not seeing whether there is anything on the screen, but I hope my friends will help me to project. Is it there? I can't, oh, it is here, okay, good. So Sorome, I'm not an activist. I have never been, and at my age, I can say without fear of contradiction that I'm unlikely. That I'm, which one? Where? In the middle? This side, not here. This side. Oh my goodness. Okay, good. We are always learning. So, Sorome was saying that I have never been an activist. I don't plan to be one. But I think, and because of that, the message I bring today on this issue, a very interesting discussion, and with a lot of things for some of us to learn about legal issues. But nonetheless, I think this is a very important subject. And what I bring to you today is just to tell you that yes, we have challenges along the line on maternal and reproductive health, but we also know that we have made some progress of some nature. It's not enough, but it is there. And let me start with, there is on the slide I see there is here showing you the trends of the population. We are now 45.9 million people in the country. High population growth, but starting to decline. Not enough, but we hope that it will continue to decline. You can see from there that trends in fertility, the fertility in Uganda is coming down from 7.4 long time ago, 30 years ago plus. Coming down slowly, but I think we are not saying that it's coming down. I don't want to scare you people here, but just know that fertility coming down is a good thing, but we should learn that we should know from most of the developed countries that if it goes down too much, it's also a problem. So Betty Chadondo and the likes of her, you need to make sure that when time comes, you alert us that it is time. Some of you know that these countries are having tremendous trouble. European countries in particular, the old ones, Japan, the US escaped they have a good progressive migration policy, so that saves them. But you'll find that we have challenges now, but they could also have the other type of challenges, and they're already having them. So Betty, you need to alert us when should we think about making sure we give incentives for our women to be able to produce. That should be on the agenda at some point. I think Olive should speak to this more than myself, but you can see there, again, maternal mortality has come down. It was stagnant for a long time. Then in the 90s, it started coming down. Then it sort of stagnated. Surprising that we had the figure of 336 per 100,000 in 2016, and This seems to have come down to 189 recently. This was rather surprising. I hope we have a good analysis of why this happened. But this is a good drop, 44%. But we need to find out why that high percentage, all of a sudden. My own feeling is that there is a reason we need to do a better analysis than we have at the moment. But nonetheless, the important thing is that maternal mortality is coming down. This is actually, of course, no woman should die, but this figure is something good. I hope we can maintain and continue to improve on it. Similarly, the child mortality, both, all the three actually, under 5, infant mortality, and neonatal, they are all coming down. The neonatal hasn't been doing very well. It is very sluggish, and of course it reflects our health services, the quality, the quantity, and the quality as well. So this is again something that we need to work on, and we should really be doing better than this if we are going to improve on both the maternal mortality and infant mortality. The next one is the progress on contraceptive use. As you can see, modern in blue, modern is going up, not as good as we would have liked, but it is there, moving up slowly, gradually, getting there. Surprisingly, traditional in orange, is that color orange or the one lower down? Yeah, I think orange. It's not, it's not going away. We actually have more traditional methods being used now than 20 years ago. Maybe Betty and Olive, you may give explanations. Is it because educated women can use traditional methods more smartly, more intelligently than the others, and therefore we may be seeing a number of educated women using traditional methods because they can manage them in a very smart way. But there could be other explanations as well. But at this time, in this modern Uganda, we still have traditional methods of family planning being used, and they are not declining as you may think. And if you also look at where women are delivering, you can see that it's going up in blue. Women are delivering in health facilities, and deliveries at home are going down, which is again a positive trend. Again, assistance at delivery, the midwives and nurses are doing a good job, 75%. Doctors at 16%, but you can see we still have traditional birth attendants doing something, and others who are not helped at all. So we have a mixed bag there, and we need to work on that and make sure that professionals can look after our women when they are delivering. I just wanted to bring in this population pyramid to show you the age structure of Uganda currently as we stand today. Those children below 14 years, 0 to 14, is 43%. Women in females, not women. Females in reproductive age group, 25.5%. The working population potential productive age group 1564 at 53%, and the elderly at 3.3%. This big group of productive age group, I don't know why they are called productive, but that is the potential workforce of Uganda, 53%. This is a good percentage that if we were able to give them the skills and the education and the employment, then we would be able to benefit from what is called a demographic dividend. But of course, as you know, currently Uganda is still having challenges along those lines. But the population age structure is still bottom heavy, and we need to work on that as well. Did it move? Has it moved? Yes. Okay, good. So you can see that both in 2014 and 2024, our population age structure is the same, and it is bottom heavy. As we said, what would be desirable is what would be like no longer just a pyramid, if it can be that shape. I don't know whether you call it a diamond shape. I'm not sure that I know what it is. But that's where we would want to go. We want to make sure that we have it. The bottom should no longer be bottom heavy, but becoming smaller. And this can only happen if fertility declines. If you track fertility over time, and fertility is coming down, then it will reduce the bottom automatically. And that's what we hope we will be able to do. So by 2040, I hope we shall have that. I think at this rate, I'm not so sure, but that's the desire of the country in terms of its population age structure. And with that, I want to conclude my remarks by saying that, yes, Uganda is making some progress in the field of maternal and reproductive health and rights. But of course, I didn't talk so much about rights, but what we also know is that we still have a number of challenges. And I hope that as we discuss today, we shall bear this in mind. Thank you very much.
Thank you very much, Dr. Musinguzi, for giving us the demographics, but also for allowing us understand where we need to put our energies and what we need to do. I'd like to say last to the next speaker, who is giving opening remarks, and this is Dr. Olive Sentumbwe, the Family and Health and Population Advisor, WHO. And like we all know, she has consistently worked around maternal and child health for years. Welcome, Dr. Sentumbwe.
Thank you very much. Honorable members of Parliament, Dr. Jotham Musinguzi, who has just spoken to us, as you heard, representatives of the Ministry of Health, very senior officials who are amongst us, Dr. Mlumba, Moses, DG, and I think a friend of Minister of Health for a long time in this particular area, which we are going to deal with today. Very many guests, Molago inclusive, and I think our care point. All protocols observed. Good afternoon, ladies and gentlemen. And I'd like to thank you very much, Afya na Haki, for making sure that we hold this platform this afternoon. Dr. Musinguzi has given us the numbers, the statistics, the demographies. And I would just like to speak to this subject as a subject we all relate to from all our different walks of life. And of course, as we may all agree by now, when we say reproductive health and maternal health, it has majorly related to women's reproductive health, I think. And there's a very big discussion and knowledge around women's rights linked to reproductive health. And therefore, when we speak about women's sexual and reproductive health, we also talk a lot about the rights, the women's rights. And it's important to know that women's rights are also human rights. And these are many, as we shall hear from probably the keynote address. But for us, basically, we've been very much around the right to life, the right to be free from torture, the right to health, the right to privacy, the right to education, and of course, the prohibition of discrimination. And as we relate to these rights, we also relate very much to the components of reproductive health, which we rarely discuss in detail, but in a programmatic sort of process. Today we see that the topic is maternal and reproductive health. But reproductive health has so many components, and I hope as we continue to think through this process, we will bring into view all these components, like the family planning, which has been huge in this presentation Dr. Msinguzi has made. But we also relate, the mother relates to the newborn, not so? Very closely. And we also know that when we talk reproductive health, we also talk STIs, including HIV. So I hope that this afternoon we shall also address ourselves to issues of adolescent sexual and reproductive health. And another topic which we hardly discuss, andropause and menopause. It has also reproductive or sexual health related issues, which may not be on the surface. We discuss issues related to reproductive system cancers. And in our area now, we have a lot of issues related to female genital mutilation, gender-based violence, interpersonal, inter-partner violence, and sexual violence. We also find out that when you're actually in the community, within groups of women and men, boys and girls, there is a lot of discussion about gender-related issues. And we all know that we are now beginning to discuss the issue of male engagement, male involvement in reproductive health as a separate gender issue, which relates to the topic we are going to discuss. I know the area of work is big, but what we need to understand, I think, as we discuss the sexual and reproductive health rights, the related concepts and concerns have a lot to do with autonomy. I think when you look at even the statistics, when you look at reproductive health within the people, within the communities, what really determines our reproductive and maternal health outcomes has a lot to do with the social norms down there in the community. It is embroiled in autonomy, control, relationships, power, respect, and of course, very important, the team that is here represents the system, the health system that provides care. But it's not only about reproductive health care. The factors that will determine whether that woman we are talking about accesses reproductive health care is under a very big influence, other than the access to health care. So given this broad nature of the issues at hand, I think today is a very timely platform when we discuss the role of the courts in the topic of sexual and reproductive health rights and the topic of reproductive health justice. Bearing in mind that sometimes actually, and Salome said that she's an activist. Okay. And that's an important term also to understand. But for Uganda in particular, I think our sexual and reproductive health needs and concerns sometimes get into conflict with the law. And it's not only Uganda, isn't it? Many other African countries have issues being discussed. The courts can be very useful in advancing policies, and in pursuing and promoting the realization of reproductive health rights in the various parts of Africa and in Uganda in particular. We hope that this lobbying, advocacy, litigation, and accountability work for the full reproductive health autonomy of the people of Uganda, which we are all working towards, will really show us results and ensure that we have improved reproductive health outcomes. I think that is what we all aspire to see, the improved reproductive health outcomes. Of course, it is majorly the women, but I think gradually we are also talking about men. Personally, I'm very excited to be part of this great team that is working towards ensuring reproductive and maternal health outcomes are improved. Because at this moment in time, when you have seen some improvements that have happened, for instance, in maternal mortality reduction, it means that we even have a lot more work to do. Because we still have standing issues which may make even our work more difficult to achieve more reduction if we don't take care of them. I would like us as a platform to therefore continue thinking that around maternal mortality, which we've done well as a country, and Dr. Msinguzi was asking, a 44% reduction in, is it 6 years, is quite significant, isn't it? But this shows that the country has really agreed that we need to do something differently. And we want to congratulate the Ministry of Health that has really ensured improved access to quality care. I think with a platform that really accounts for the deaths of mothers and newborns that happen. There is an accountability framework now at the Ministry of Health, and we can only make this better, both at the national level and the district level. But I want us also to think that if we are going to make more improvements, we need to step up our contraceptive use. This business of improving and staying at 30 what? 35. And we are the lowest in the what? In the East African region. But we know that family planning or contraception is pillar number 1 to what? To improving maternal health and therefore safe motherhood. So as Ugandans or Ugandan populations, we really have a lot to do something about our uncontrolled fertility. If we are going to further reduce the maternal mortality, we have to work harder now in these related areas. Because if we push out about 1.9 million women every year and putting them at risk of a pregnancy, it would be difficult for us to sustain this gain. Another area we need to really look at very closely is the area of adolescent pregnancy. If we are pushing these young girls, 15 to 19, what contribution are they making? 24% to this maternal mortality. 28. The figures may differ according to where you were slightly. But it's a huge contribution, isn't it? And if we don't do something about reducing adolescent pregnancy in our communities, then we shall find it difficult to further reduce the maternal mortality. So we should be concerned, all of us, to mainstream this reduction of adolescent pregnancy in our programs. But we've also learned as we went along that violence against women and girls is probably behind adolescent pregnancy. There is a link. And these are huge women's rights violations, young girls' rights violations. And we need to do something about that if we are to further reduce the obvious maternal health gain. And I think right now there are very major discussions around the fact that if we really, really want to even do a further reduction in the area of maternal mortality, and if we are going to work on family planning and contraception, if you are going to work on adolescent pregnancy, if you are going to work on violence against women, then you need to engage men in the issue of sexual and reproductive health. And so when we are interrogating reproductive health justice, some of these areas should come into view as we plan about ensuring that the reproductive health rights and justice is actually making meaning to the people we represent. Ladies and gentlemen, ensuring reproductive health rights and justice means thinking through our cultural and religious norms, socio-economic barriers, and other vulnerabilities, which are so many depending on where we are, our geography, where are you. If you are in a Kalangala, maybe you have slightly different vulnerabilities compared to the person who is seated here in Sheraton, isn't it? And so even when we are planning and advocating for reproductive health justice and rights, we have to take these different vulnerabilities into view. And not only the availing of services, because availing services, these other factors may make it impossible for those intended women or girls or men to actually access them if we do not address the bigger components that influence the sexual and reproductive health rights and justice. We must remember to create community awareness on what sexual and reproductive health rights are and what they are not, because there has been a lot of misinterpretation and a lot of misunderstanding on what reproductive health rights and what reproductive health justice is. As you know, for instance, and this is maybe for Salome, it's only the uterus, which is a human organ with a number of laws governing it. And even this alone has serious implications for some of the work we are doing. But for Afya na Haki, this is a great opportunity, a great platform to begin to discuss some of these roles, some of the laws which sometimes inhibit access to services. And it's going to be very important now to really strengthen this reproductive justice lens if we are going to strengthen sexual and reproductive health and gender equity in our programs as reproductive health stakeholders. I hope there will be a continuous engagement of communities at all levels to enable them comprehend what we may be talking about now in this hotel and what we are trying to do to advance maternal and reproductive health, and make sure that the communities we intend to impact are really with us at the same pace of understanding, and that they are involved in tracking the work we are doing and how we are doing it, and they are also participating. It is good and it's the right thing to do that we engage beyond ourselves, because those numbers which were shown are actually made by those what? People, those communities. Ahaki, we pledge to work with you in all the efforts to equip the real men and women who make the numbers, the real boys and girls in their various walks of life, with the theoretical and practical knowledge which we are going to learn about today, beginning today, about the concept of sexual and reproductive health and sexual and reproductive health justice. If we are going to realize sexual and reproductive health positive outcomes for Ugandans. We will, however, need to enhance the availability of disaggregated data We need to do more research. We need more positive policies. We need more resources. And indeed, we need to improve governance and leadership around reproductive health justice. We commend your reproductive health care advocacy efforts, but make it simple so that our efforts, your efforts, can benefit the grassroots communities in the languages they speak. I thank you for giving us this opportunity to have these deliberations begin. Thank you and wishing you successful deliberations.
Thank you very much, Dr. Sentumbwe. And thank you for bringing to light a number of issues, especially the social determinants, but also having the role of courts beyond the courts, bringing together communities, getting everybody to speed, as well as moving the conversation of maternal and reproductive away from a burden of women to where it is a societal problem, and therefore the solutions should be societal. I'd like to move us to the next speaker, who is going to speak for a few minutes, because after that we're also now going to delve deeper into some of the experiences of using the courts of law. Madam Fatia Kiange, the Executive Director of SEHAT. Like we all know, many of us are doing all this great work because of something called Petition 16, that we can boldly pull our shoulders on that. So Fatia, how do you see things happening? Please come and give us a few words and then we can move on. That's not enough, especially those claps are not gendered.
Thank you so much, Salome. Thank you so much. And thank you so much, Afya na Haki team, for inviting us and for the collaboration in improving maternal health and reproductive health using the law. I'm so delighted to be here and excited to see the kind of delegates that are here. So allow me to stand on the protocol that has already been set out. Of course, I have to recognize our members of parliament here. I have to recognize Dr. Musinguzi. I have to recognize the Ministry of Health representatives, the WHO, Dr. Mulumba and the Afya na Haki team, the judiciary, and the government, other government ministries, and of course, the civil society organizations, because I know how much the CSOs have contributed to this work. So I want to recognize you, and of course, our foreign missions and development partners that are here for supporting this work. I do think in my reflections that this is a very important afternoon and deliberations where we are actually reflecting on the role of the law in realizing the right to health. Very, very important. And I think we are here to even demystify the fact that there is a lot of perhaps we are. They're saying that our neighboring countries, our African countries come here, they pick on our very good laws, our very good policies, and before we know it, they are implementing those laws and policies to improve the health of the population. And I'm glad that the discussion this afternoon is going to demonstrate that actually we can move our laws and our policies from the papers to actual practice for the benefit of our population. So I'm delighted to be here for that reason. And definitely, I know we are going to reflect on the Petition 16, like she has said. And before I even say something about Petition 16, it's even to go back to what Dr. Olive was telling us, that the right to health, yes, it's the healthcare services, but it's also the social determinants of health, as we'll see. That, and I think, yes, we are using the law within the health sector, but I think it's time for us to also extend the use of the law to other sectors, because other sectors represent the social determinants of health. The transport sector, the trade sector, the agriculture sector, the gender sector, gender and social development, the education sector. How do they contribute to issues of maternal and reproductive health? They have a big contribution, and indeed, it's time for us to also think about using the law to ensure that perhaps our reduction, maybe next UDHS will even be much, maybe 60% or even more. So just to say something on Petition 16, I really want to appreciate the Ministry of Health for taking Petition 16 court judgment, and implementing it. And I know that we have worked closely with the ministry to implement Petition 16. This is the landmark court judgment of 2020 on maternal health. But even before that, I want to appreciate the courts of law that were able to give us a positive court judgment, because I'm almost sure that if it has not contributed to the 44%, perhaps in the next reduction figure, it could have contributed. Why? Because we've seen that Ministry of Health picked up on this court judgment, of course, with us moving this journey with them, and have done an implementation of the court decisions. And I think we've seen so many countries also coming to Uganda to learn from Uganda how this law has impacted on maternal health. I'm sure in the panel discussion, we are going to see more details in terms of how the ministry has implemented Petition 16 in collaboration with all of us. Allow me to appreciate the CSOs, the 9-year journey that the CSOs led by SEHAD undertook with the leadership of Dr. Muluman team then, to be patient for this court judgment. And perhaps what I want to say about this is the role of civil society organizations. That civil society organizations are very central to contributing towards the improvement of our health indicators in the country, specifically on maternal and reproductive health, and that this Petition 16 is demonstrating how CSOs have been instrumental in working with government to see that we actually improve maternal health and sexual reproductive health in the country. I want to appreciate the WHO, represented by Dr. Sentumbwe here, for the energy and momentum you have created around MPD-SR. Maternal perinatal death surveillance and response, and I know that you're again establishing collaborations with us on that, and clearly I can see that we are even going to do better given that direction by the WHO and that momentum by WHO working with the partners. Thank you so much.
Thank you very much,
Again,
Fatia.
I want to appreciate Afiana Haki for organizing the meeting.
Thank you very much, the Executive Director of SEHAD, for giving us just a snippet of Petition 16. We're going to have a conversation now from another lens. Remember, we said we are here as stakeholders coming from various walks of life and various sectors, but we are all concerned about maternal and reproductive health. So I'd like, in the same spirit, to welcome Dr. Robert Mutumba from the Ministry of Health, Assistant Commissioner, Health Services, to come and tell us what is happening in the Ministry of Health. What is cooking there? You're welcome, Dr. Mutumba.
Thank you so much, and I'll also request to ride on the earlier protocol established, but you will allow me to welcome the Honorable Minister for Constitutional Affairs, Honorable Mao. You're most welcome to participate in this conversation. Dr. Robert Mutumba is my name. I'm an Assistant Commissioner, Health Services, but representing the Director of Public Health, Dr. Daniel, who, because of other engagements, has not been able to make it to this meeting. But I will ably deliver his remarks. I would like to begin by acknowledging the contribution of our Haki team towards shaping Uganda's the RAMCAP platforms in terms of the service delivery. They have participated heavily in undertaking research that has informed policy, but also a number of interventions within the programs for reducing the burden of maternal and newborn mortality in the country. We acknowledge that the work emphasizes the importance of holistic, person and community-centered service provision that takes into account both individual and societal circumstances that affect access to sexual and reproductive health services. So my interpretation of this is that in order to comprehensively address maternal health needs, there is need for a multi-sectoral collaboration. We need to work together, not just leaving this work for the health sector alone, but we need to embrace approaches of working together for us to be able to address barriers in accessing health services. Additionally, reproductive justice recognizes that historically marginalized communities such as women and girls, sexual minorities, face significant barriers in accessing health care and other resources necessary for their sexual and reproductive well-being. Consequently, addressing structural and systemic inequalities to promote care and wellness through policies or programs is very central to the reproductive justice. The research also recognizes the value of litigation in establishing mechanisms requiring government to report steps taken towards fulfilling its duty in the right to provide health to the citizens, to Ugandans. In terms of the ministry's role in reducing maternal mortality in the country, as earlier presented by the Senior Presidential Advisor on Population, Dr. Jotham, we note that Uganda, we have had a significant reduction in the number of mothers who die, and he ably shared the statistics. But this has actually been a result of concerted efforts of everyone. The Ministry of Health has led efforts in understanding the burden of maternal mortality, and on a weekly basis, in the room we have Bruno Semwanga and the team. These gentlemen analyze data on how many mothers we are losing in the country every week. And so every week we have a meeting on Thursday where mothers who die the previous week, such reports are discussed, and teams really work together to addressing the drivers, or especially the avoidable factors that lead to the death of these mothers and babies. And I know it's been quite tiresome work, but this is something that we are undertaking as a Ministry of Health. So we know what is actually leading to the death of the mothers and the babies in the country, and we are working together we acknowledge the support from the different development partners, WHO, the UN family, USAID, World Bank, and many others that have really heavily supported, complemented the effort of government in seeing this reduction that has been presented. The report, so every year we also publish a report on why mothers and babies die in the country, and this report is actually also shared with the Speaker and Parliament and different other entities, and they are able to clearly appreciate some of the persistent bottlenecks, and we are working towards addressing all these, but really in a multi-sectoral approach. We want to thank the Minister of Education, Minister of Gender, and colleagues from other sister ministries, departments, and agencies for the support. At the national level, we have specific subcommittees, really like those focusing on the newborn. Over the years, you note that we have not done very well in terms of reducing, the curve in terms of the babies who die. When you look at the report on the babies whom we lose per week, you really see that they are still quite a high number, but we see that the curve, the numbers are reducing, but less for the baby deaths, and I think it also should be a subject for us to continue to focus. At the subnational level, we have decentralized the efforts, the response. So you'll hear of local maternity and neonatal systems. So initially, we were discussing a lot at the national level, but we noted that it's very important that we decentralize these discussions and efforts. So I'm glad to report that across all the 18 regions in the country, we have these discussions on why are mothers and babies dying, but also real-time interventions have been initiated. There are WhatsApp groups, even at midnight, as some of us are sleeping. People are really discussing. A gynecologist, a midwife somewhere is actually requesting for support. Do you have blood? And a lot of these efforts have really yielded, and we want to really thank the partners that are supporting the government in this response. So the ministry operates a knowledge management portal where we have the statistics and all these issues we are discussing published. And lastly, in this regard, is we are implementing, we call them quality improvement initiatives. After understanding why our mothers and babies are dying, one of the major issues I can mention is that we have a lot of women who attend antenatal care. They go to our health facilities, but for some of these mothers, the risks are not picked up during antenatal. So we are implementing targeted risk, identification of these mothers with risks during antenatal and ensuring that they are really followed up to ensure that they have a safe delivery. We are glad that the institutional deliveries, the number of mothers who are now delivering from health facilities, we have improved. Dr. Jotham mentioned we are now at the UDHS 2022 survey shows that 91% of all mothers in this country are delivering from health facilities, and that's very significant. For WHO states clearly that for countries that want to reduce maternal deaths, they must ensure that all women deliver under-skilled birth attendants, and those are health workers. We are glad that we've been able to really get to the 91% mark, but we look forward to ensuring that all women in this country deliver from health facilities under qualified attendants. As I conclude, it has been very, 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 very critical for us to engage with the civil society. The civil society has created a lot of demand at the community level, and we see an increase in uptake of a number of, sexual and reproductive health services, including the antenatal care. I think some of the persistent issues are around male involvement, and the good thing is that we have quite a number of men in this room, so probably we'll have a further conversation around, the issue of, that factor. When Bruno and the team are analyzing avoidable factors as to why mother X died, there are a number of times where we see the partner was not supportive, and the partner, they are talking about the man. So I think that's those are some of the thoughts and, discussions that we continue to have to further refine our national male involvement strategy. Lastly is really the collaboration that I've earlier mentioned with other ministries, the Ministry of Gender, the Ministry of Education. So as a Ministry of Health, we continue to appreciate the fact that these issues cannot be addressed by the Ministry of Health alone, but we need to do this in collaboration, in partnership with everyone. So strengthening the coordination and management of maternal and newborn health service delivery, monitoring and evaluation, and identifying priority research areas and developing a research agenda for improving maternal and newborn health outcomes is going to continue to be critical and top on our agenda. I thank you.
Thank you very much, Dr. Mutumba, for having given us where the ministry is, but also to indicate that this is multisectoral. You're looking at this with other ministries, that you're moving health away from only health to other sectors, at the same time using technology and harnessing the power of digitalization, having the conversations around surveillance, because that's part of us seeing whether we are moving. So now all these conversations we're going to deepen. We are actually now appetizing you. This is to appetize ourselves. But before we appetize ourselves, I'd like you to fill your glasses. Yes, with water. Water is life. Fill your glasses. Why don't people trust me? And those of you who are joining us online on YouTube, on X, and other platforms, also fill your glasses wherever you are. Yes, before you aspire for anything, you need to celebrate what you have. From the opening remarks we've gotten from civil society, from the Ministry of Health, from WHO, from the Senior Presidential Advisor on Population and Family Matters, we have moved miles. We are making some progress. We are not yet there, but we have moved a bit. So can you please toast to water? Can you imagine? You're so lucky, toasting to water. A toast. Celebrate each other around the table. Celebrate each other. We have moved miles and we've all traveled that journey. Policymakers, judiciary, parliaments, ministries, technical officers, people who work on ground, people who do a lot of work wherever they are. We've all contributed to that. So now that we've taken a sip of water and toasted, I'd like to formally welcome our 3 chief guests because they are now all in the room. I'd like to formally, with so much humility, to welcome His Excellency, Hoest van Itro. I hope I have tried to be very Dutch. Okay? The Deputy Ambassador and Head of Development Cooperation for the Royal Netherlands Embassy in Kampala. Your Excellency, you are welcome. For those of you that have been in the SRHR sector and human rights sector for long, we know that the Royal Netherlands Embassy has stood the test of time of investing in these critical sectors. You are welcome, Your Excellency. And then I'd like also to welcome Honorable Norbert Mao. Mugole. Honorable Norbert Mao, the Minister of Justice and Constitutional Affairs, and the President General of the Democratic Party. But most of us know, when he was still in Parliament, as a member of Parliament representing Gulu, he was one of the people who would always run to issues regarding gender, maternal, human rights, etc. So he's not new to this conversation, only has changed space, and it is a strategic space. You're welcome, our chief guest, Honorable Mao. I'd also like to take an opportunity to welcome Honorable Justice Cheboroin Barishaki. When we talk about Petition 16, somebody was willing enough to create a footprint. And he's actually going to share with us what did it mean to walk that journey, but also what does it mean to ensure that we can advance maternal and reproductive health within the judiciary. So now we are full house, including all of you that are online and are joining us. You are all welcome. We are now ready to have the deeper conversation. Without much ado, I'd like to welcome our keynote speaker, Dr. Moses Mulumba. You're welcome.
The Honorable Chief Guest, I will stand on the protocol as has been provided. Today I must say that I'm one of the happiest human beings around, because what I see in the room is a dream. As a legal person that crossed over to health systems work, sometimes I feel confused and I keep wondering how we can create this relationship between health systems and the justice systems in a way that invokes the power that that collaboration has. And for a very long time, it has been a dream. Being in the room with the Honorable Minister of Justice, the Minister of Health, WHO, Justice Cheborion, and all the partners that are in the room, I think it's super, super exciting for us to be acknowledging and actually acting on the fact that there is a role that courts and the judiciary and the justice system can play in ensuring that our health systems are much better than they are. And I have a lot to say, but allow me to just start with, I don't know where this, I need help. Okay. Allow me to just start with a very interesting case that introduced me and invoked my emotions as a young legal practitioner to actually think about the role of the law and maternal health in ways that you may never imagine. And this case, in one way or another, triggered the famous petition 16 that my colleagues at SEHAD worked on many years ago. We had the case of Joyce Nakachwa in 2001, who was delivering a baby alongside a city council clinic. Right now, there is a Chinese hospital. That clinic, if you remember it, it used to be a place where young girls go to deliver. So Joyce Nakachwa was such. So she went to deliver. She couldn't reach. Before she delivered, she finished the delivery, the baby was still attached to her. The hospital referred her to Mulago. There was no, referral note whatsoever, but the hospital was not able to give her the services that she needed. So she continued bleeding and weak, but then she walked to the referral hospital. And along the way, she was forced to sit outside very early in the morning, and later was rescued by people and taken to a private clinic. And then, after the clinic finished the work, she returned home. During that time, there was a whole conversation on baby theft in Kampala. Now, she was so unlucky. She was one that had not showed signs that she was pregnant. So the border guys around actually alleged that the baby she had crying in the house had been stolen. She was forced out of the house by the mob and examined. The LC leader used a polythene bag, opened her up, and examined her in full view of the residents. And the police eventually came, arrested her as a suspect. They took her and the baby, and they put her behind the police patrol car. You know how our police arrests. So the baby was eventually removed away from her. And when she went, the police went back to the city clinic to confirm if indeed she had delivered. And they confirmed to the police that she had indeed delivered. But even then, police kept her in custody for another 5 days and only asked the police surgeon to examine her after the 5 days, after inmates had complained that the smell she was having was not coming off well. So she was released on police bond after 5 days in detention without any charges, and she went to look for her baby. She was kept in suspense for a week and eventually told that the baby had been taken to Sanyu Baby's home. On reaching the Sanyu Baby's home, she learned that the baby had died. But she was not sure that the baby who had died was actually hers, because the burial permit was indicating that the baby they had buried was 2 days old, and yet hers would be 11 days old. So a lawyer in Kampala then, Philip Karugaba, who he was doing a lot of public interest cases on environment at the moment, he picked up this case and he approached court over the violation of her constitutional rights, including the constitutional rights under Article 33, which says, women should be provided with what they need to enable them perform their natural maternal functions. And now, the semantics of legal play around were very difficult, as I'll be indicating. And it took a number of days. Just before the case was heard, Nakachwa died. Now, this case had interesting things because it had a main case, it had the preliminary objection. Preliminary objection simply means that before the full case is heard, someone is opposed to a procedural issue. And then it had the constitutional appeal eventually on a number of things. Many of the people who argued this case are now very senior, and I don't know what they would think if they went back to think about the case. So Dennis Birije, on behalf of the state, raised a preliminary objection, and this objection was based on the fact that she had filed her case 2 days later than the prescribed statutory time, because under these cases you must file within 30 days. So it was after 32 days that she filed the case. And it became a whole issue that took, the legal jargons and everything. And then Philip Karugawa was working with Counsel Irene Mulyagonja. At that time, she was known as she is. She was a lawyer in town. So she argued that emphasizing, procedural issues, as Legal Notice Number 4 of 1996 had indicated, was not within the constitutional aspirations, where the Constitution actually recognizes rights. And she argued in the alternative that if you do not actually take that argument, she argued that when do you count the 30 days when this case we would begin counting them? Because all the other days that you're talking about, she had no idea that her baby would die, and eventually she could not have approached the court immediately the violation had happened. So a preliminary objection was upheld, was rejected, and the court proceeded. But then, what I want to share that was very interesting was that eventually the case never discussed maternal health and the maternal health issues. The conversations in the case were on the preliminary objections and whether after Nakachwa had died, the lawyer who was representing her stood the right to actually represent her after her death. Because the lawyer had argued in the Constitutional Court that when a person dies, the right to sue or represent her is a property. So she doesn't die with the property. So the case ended up as a property issue. And the Constitutional Court, Justice Kanye Ihamba eventually, and the rest of the team agreed that a petition, which is a chosen action, is also property which is, this was the argument of the lawyer. He was arguing that the petition was a property which can be inherited, and the lawyer can argue it on behalf of the person that he was representing after the person had died. Justice Kanye Ihamba disagreed with the rest of the judges, and they argued that the right to the petition is optional to the holder, and it's not a right that is inheritable. Now, a huge opportunity was lost in this case. This case was presented at Regency Hotel. It's no longer also a hotel. I passed there a few days ago in Bakuli. So Philip Karugaba came to present this case to us as students. And the issue was on property rights, never maternal health and the issues that had raised and the injustices that were there. As an individual, I picked this up, and I thought that there was a real opportunity to actually begin thinking about maternal health as a justice issue, because within the justice system, there would be a number of things that would be tried and settled if a case like that would be brought before the courts of law. So we began thinking about how would we engage. And the only time that there has been a relationship between the law and the health system that we found after law school had been that, you either argue the case as a tort or argue it as any other thing, but never as a health systems issue. And there was a missed opportunity. So that's how petition 16, that's how we began thinking about petition 16 when these cases came up, and it ended up coming before you Honorable Justice Cheborion and the panel that you worked with. So, over the years, it's over 20 years now, I have learned that, and I interest people, that there is a serious relationship between health systems and the law. But this relationship has been evolving over time. And it has very complex issues, very simple issues, but also very complex issues. These days, when you talk about delivery of health care, you cannot talk about health insurance. Now, when in law school they are teaching insurance, it's a contract, and they teach you about insurance law, but not the complexities of health insurance and what it means, and the urgency that it actually requires. We are talking about assisted reproductive technology lately. These are all just legal things that we talk about, and yet they come back and impact on women and men who are actually approaching the health system to receive the assisted reproduction every single day. I have come across an interesting term which is evolving also, the term legal epidemiology. And I'm interesting very many people around it. Maybe because of the over-interaction with the law and health systems, I find it an interesting concept and very useful, as I'll be sharing later, because it talks about how sometimes the law can be a cause of diseases. It also talks about the fact that sometimes the law can be a vehicle for the distribution of diseases. But at the same time, the law sometimes can be used as a prevention mechanism for the diseases and the injury to the population in many ways. And if you unpack it, it has several other things. And I think that this conversation is not just academic anymore. When you think about Petition 16, you think about the judgment and what the ministry is now presenting as has changed, and the entire process that we went through of 10 years of litigating the maternal health cases, and the changes that I saw in the ministry, from receiving calls in the people who were in the ministry then to actually say, thank you very much, young people, for filing this case, but we are supposed to be responding to it, to actually seeing the ministry sometimes getting into panic and passing all sorts of rules and regulations around maternal health. Some of the maternal health audits that are being talked about, we actually saw them. When the case was filed, the ministry issued a requirement that maternal health audits were now mandatory and they had to do them. And it became an issue of the doctor, not the issue of the health system. So the doctors and the health professionals now were being condemned for the death of the mothers rather than looking into the issues that are in the systems. And we saw so many doctors arrested around that time. So other DCs were arresting the doctors based on what had actually come out of the case that had, even before it was decided. So we've seen that sometimes when the laws are invoked, they can have a very positive response and decisions on health systems. But we've also seen situations where the laws are invoked and they are a problem. And this is wider. Sometimes when you look at the law and think about maternal health within the wider public health spectrum, you think about many things that Professor Larry Gostin has indicated. The fact about the power of the state and the duties of the state. How you unpack the power, the legal powers and the duties of the state, and how the state also sometimes interacts with third parties. What does this mean for maternal health, for instance? The power sometimes of constraining the power of the state itself. In COVID-19, it used to be the presidential address. In many cases, the president comes on TV and says, tomorrow, beginning this time, anyone who does this and this is going to be arrested. And that was the law. And when I thought about this law that was being implemented in many cases, it was a colonial legislation, the Public Health Act. of 19, it was at that time we were counting 80 years. And we wrote a publication saying, how do you deal with an 80-year-old legislation in a situation like COVID-19? And we've seen that same legislation, which are even older than the public health legislation in the area of sexual reproductive health and rights, have been applied for a very long time. The control of syphilis and other venereal diseases has been controlled through a legislation that is almost 90 years. And when you read the provisions of this legislation, which has now been annulled by the new Public Health Act, you know, if I suspect that you have a venereal disease, I had all the powers to actually go and report you if I'm employing you, and you'd be arrested for a long time. So all these legislations that have been kept on the law books for a very long time are legislations that empower the state, but sometimes they also constrain the state in a way that could be useful, but we've not actually interacted with the systems as much as we ought to be interacting with the system that we need to. So, now, today the subject would be much wider than you can imagine. But the question today is on the role of judges and what judges can actually be able to do and the courts of law can be able to do in improving health systems. I know that many of you are aware that as the US gets to the elections lately, the judiciary is playing a major role in shaping the policy spaces. And one of those areas that has been very, very difficult has been the area of access to safe and legal abortion in the US, where when you have a certain political party, the policy decision changes on access to safe and legal abortion. But when that political party loses elections and say, you know, the Democrats now have lost, it's the Republicans change the entire spectrum on access to safe and legal abortion. It's not just a political issue. It's an issue that affects the women, that affects maternal health. But the courts have played a major role around it. And I agree with Professor Loko Nyango, who has written a book on the role of judges. And he has argued that while in many cases, especially public interest cases, we argue that politics is far away from the judges' chambers, sometimes we are not right. Because the issues that the judges are making decisions about are issues that have intense social, cultural, and political contestations. And therefore, everyone will be waiting to see what the decision actually is. So according to him, the judges, in a way, cannot be said as insulated from the politics itself. So it's the same with maternal health and sexual reproductive health and rights. Many of the issues that we actually talk about are about allocation of resources, are about political decisions and choices that we talk about. But we never create the spaces like this to actually talk about these issues as much as we have to be talking about them. And in Uganda, we've tested this. When we filed Constitutional Petition 16, the first political issue that was raised by a senior state attorney then, who is now a justice of the High Court, Patricia Mutesi, was that the issues of maternal health are political issues. And she sustained an argument that when you talk about maternal health, it's a government policy issue that is never justiciable, and it's a political question. And the Constitutional Court then agreed with her that indeed, these are political issues, and the judges do not have the capacity to actually appreciate and understand maternal health issues as policy issues. We never agreed with this judgment, and we appealed. When we appealed, we had the Constitutional Appeal number 1 of 2013 to the Supreme Court, and the judges agreed that indeed maternal health cannot be simply argued as a political question issue. It's an issue that is beyond politics sometimes. And as I cite Justice Esther Chisachi, as she then was, she said that the political question doctrine has only limited application in our context, because in many cases, it is only insulating the executive and the legislature from some roles. But sometimes the private individuals can feel that there are issues that are not political, but are to do with rights, and they have been affected. So the judges cannot run away from making decisions that would ideally look like political decisions. So we achieved a lot when we actually were able to then bring back the judges to make decisions that are policy in nature. And some of these policy issues have been around maternal health for a long time. Again, as I indicated, sexual reproductive health and rights is full of contested things, is full of colonial issues, is full of religious issues. But the history has been that sexual reproductive health and rights and maternal health has been governed through cultures and religions and taboos. But every society that you can think about has moved beyond cultures, religions, and taboos, and they have reduced these into legislations and the policies. It therefore means that since issues of SRHR and maternal health are now part of the law, we cannot insulate the judges and the role of judges in making sure that we have justice in maternal health and sexual reproductive health and rights. So it squarely puts them into the importance of making decisions around the issues of maternal health. This thing is not, I may need help. I don't know whether it's a battery. It's either moving very fast or very slow. Yeah, but beyond the role of the judges, I think the other documents that we can't run away as health practitioners and public health people are the constitutions. Because the constitutions then anchor many of the maternal health and sexual reproductive health rights issues that we are talking about into the mother document of the country. So you'll find that in many cases, sexual reproductive health and rights are actually part of the maternal health, the constitutional issues that are being talked about, either directly or through other rights like the right to health, or the right to life, or through individual group rights. When you talk about the rights of women or rights of children, in the context of Uganda, Article 33 has anchored maternal health very squarely within the rights of women. But sometimes in other countries we've found that even when you do not have a substantive constitutional provision, you actually have it as part of the principles of state policy, which is very important to think about. And in other countries, the constitutions have actually invited the international human rights instruments, and they have made maternal health as part of the rights that are justiciable in the country, but also as part of the country obligations that the country in many cases have. So over and above that, we've seen that strategic litigation plays a major role in maternal health. So we cannot talk about Petition 16 without thinking about what strategic litigation is. For the non-lawyers, strategic litigation simply involves a process of selecting a potential case that could advance a specific legal, social, or human rights change. That's where we found that many cases that are to do with maternal health are actually now coming through strategic litigation cases which are being brought by civil society organizations. But strategic litigation can only play that role when the cases have been consciously thought about, not just bring the cases before the judges. And as the judge may highlight, in many cases the judge's hands are tied when you bring a strategic case that you think is strategic, but you bring it in a manner that is not strategic. So it's something to think about. And we've seen so many cases that have been very valuable in undertaking that. And there have been very many cases. So Petition 16 that we talked about has been there. And I'll just go through these very, very quickly as examples. I have talked about the fact that, beyond filing the case of mothers that had died, we had the political question doctrine that we had to deal with. and eventually very interesting judgment that we had from Justice Cheberion that we'll be talking about, actually indicating that mothers have a right, and this right is enshrined in the Constitution. But many of these things are not just talked about, but you find them in media, you find them through advocacy, and you also find them in the policy space that becomes very important. Now, when Constitutional Petition 16 was filed and eventually first thrown out, one of the arguments was that the case had to be filed as a case that was on violation of rights. We had the second case filed again through colleagues at SEHAD, where Nakaseke Hospital, a doctor had reported on duty, but that on reporting on duty, he had hung his jacket and he had taken a car to town. So a mother came, she needed the attention of the doctor to deliver. Similar circumstances like the cases in Petition 16, and the doctor was never there. So the mother's uterus ruptured. When it ruptured, she died, and the husband eventually came trying to get justice for the wife that had died. So Nakaseke local government was dragged before the High Court, and this case was based on the fact that the argument was that Nakaseke Hospital had failed to supervise the doctors and other health professionals to ensure that these health professionals actually are in the duty stations when they are needed. So Nakaseke Hospital lost this case. The High Court, led by High Court Judge Benjamin Kabito, went to Nakaseke Hospital to actually see the situation that was being talked about. Where does the doctor sleep? Where does the doctor sit? What are the conditions of the doctor? So he did the locus visit. And this case, eventually, when Nakaseke Hospital, it had to pay 35 million shillings, which they have been paying to the family. But there have been so many changes. In fact, when they tell you in Nakaseke Hospital, when priority hospitals were being selected for improvement, Nakaseke came on and was almost #1 in some of the World Bank funded projects, I think. And many of the things that we are talked about were changed. But Nakaseke Hospital was arguing that we have been sued and people are holding us accountable. So now we need to see that there is improvement. And there's been a lot of improvement in Nakaseke Hospital over the years. It's not the only case. Mulago lost a baby. A mother went to deliver in Mulago. When she went to deliver, she was sure she had given birth to twins. She was given only one baby to go home. When she reached home, she insisted that indeed she had delivered twins and one of her babies had not been given to her. So they still walked to SEHAD. I was still leading the institution when they walked to the Uganda Human Rights Commission, indeed, actually. They first walked to the Human Rights Commission to have their rights vindicated, and the Uganda Human Rights Commission referred them to SEHAD at a time. And we filed a case to simply argue that the case had clearly indicated that the mother had lost her baby. When we did a lot of preliminary investigations, it was found that indeed the mother had delivered 2 babies. When still they gave her a dead body, she had been given a dead body, that when we did a DNA with her, the dead body never matched the parents. So it was still a very strange case where Mulago had lost a baby, and now we had 2 situations where another dead body now had been given to a wrong mother, and we kept wondering where the other dead body now had, to the other family, where it would come from. So we've had a series of cases where babies are lost in the hospital and sometimes are mixed up and it becomes an issue. Still, we went before the High Court, and Justice Lydia Mugambe gave a very progressive judgment, and she argued that the safety of the mothers and the safety of the babies in the hospitals is part of their constitutional rights. And this family has been awarded money. Of course, it can never replace the baby that was lost, but it shows you the classic examples of where cases of maternal health have been litigated and have led to so many things. We've also had another case on comprehensive sexuality education. The members of parliament simply woke up and they said, we are banning comprehensive sexuality education. Now, our argument was that how do you ban what you have not regulated? We still went to the High Court and argued that there is need to actually regulate sexuality education. But you cannot simply wake up with a blanket ban and you ban. We still got a very good positive judgment on that, and the Ministry of Education was required to fasten the process, a comprehensive sexuality education framework, which they have worked on. It continues to be contested, but there has been at least seeing that the litigation has been a catalyst in one or another to make sure that things are done. I think there are many situations that one could talk about, and I think I'll straight away go to some of the things to think about, because we've been in a situation now where we have more progressive policies on maternal health and sexual reproductive health and rights, but those policies are not matching the laws. And the people are being told, who are in the policies in the Ministry of Health, that no matter how progressive your policy is, it cannot replace an existing legislation. And the existing legislation is a colonial legislation. So we have those situations that we need to look at and actually ensure that they are dealt with. But as I indicated, I think all signs are very clear, and it's been very progressive that indeed we now have some sense of hope that the judges can play a major role. But these judges, we have left them to self-educate themselves on maternal health. We've not designed the programs that are sufficient to actually ensure that they get into the spaces. The funding partners have not funded the judges sufficiently to ensure that when they're handling some of these issues, they're actually much more aware and that they interact with them as issues are very dear to them. This has refused to move, but I want to move to the last slide. So I needed the last slide. So I wanted to conclude. Of course, there are so many things to invoke the conversation this afternoon. But the judiciary plays a major role in challenging a lot of legacies, including colonial legacies, very colonial laws, but also anti-poor legislations, and some of the criminal laws that have continued to be a challenge on the African continent and in Uganda itself. But as I've indicated, it is only in situations when these issues have been brought before the judiciary that we've seen those changes. It's also been interesting that this contemporary discussion needs to happen, but the space has not been created. Every time doctors and medical professionals face the judiciary, it is the situations when the judges are asking them tough questions as expert witnesses. And some doctors don't want to appear before the judicial systems at all because of what is happening. So the Honorable Minister of Justice, I'm happy that you're here, thinking about how this relationship can be made much better to ensure that situations like maternal health and sexual reproductive health and rights are actually dealt with. But also the role of Parliament and the role of the Minister of Justice in looking at the colonial legislation that continues to exist, not just the Public Health Act that has been dealt with, the current penal code provisions that are still talking about very old, archaic legislation that don't permit sexuality education in one or another, that don't deal with the age of consent. Consent in reproductive rights has remained a contested issue. Is consent to marriage the same as consent to access information for reproductive rights? Is it the same as consent to treatment? All these are gaps that have not been dealt with the judicial system. And yet there are important issues that continue to appear before the judges, and they become very, very important. I think as I conclude, as Justice Cheborio has highlighted in Constitutional Petition 16 in the judgment, there is hope. The judges recognize the fact that there are weaknesses, but there are also opportunities. And they recognize the fact that if you measure the constitutional provisions versus what we actually see in sexual reproductive health and rights and maternal health, there are gray areas that we'll still need to deal with. I'll stop there and hand over back to the facilitator. Thank you very much.
Thank you very much. Have we got an appetite? Are we getting appetite? Personally, I'm salivating as to what next is coming. Where we ended is where we're going now to continue. We're going to have Honorable Justice to come and delve deeper, because we ended with a quote. Now we're going to get deeper into the experiences. You're welcome. Justice Chebron. Let's clap.
Thank you so much, MC. The Honorable Minister of Justice and Constitutional Affairs, Honorable Mao, Your Excellency the Ambassador who is with us, and all protocol observed. I'll begin by thanking Afya na Haki for the invite to participate in this discussion. And I think it's healthy to do so, in my view. Even if I'm a judge, I'm not supposed to descend into the arena, because we have many of these cases still coming up. But discussions of this nature enrich us. I want to begin by saying that in Uganda we follow the common law system. And in the common law system, we do not descend into the arena. We are not like civil law judges who can see things going wrong and they give evidence. For us, we'll fold our hands, even if we saw the person being killed, because it has to come from somebody. So that is how we practice in this country. So many things will come up. It will take a proactive judge to step out a little where the law mentions an aspect and deal with it. So when you talk about the case which the doctor talked about of Nakachwa, where the court said, when one principal state attorney said, no, you came too late, 2 days late. A proactive judge will look at the Constitution, which says substantive justice must be done. You don't have to go into technicalities. These issues of time are technicalities. So the judge must come out and be able to go into that, even if any of the sides or any of the lawyers has not mentioned. So some of these things will depend a lot of times on how the individual judge looks at a matter. If you want a matter to go on and address the main issues, you will say, no, look at this provision of the Constitution. It allows that you must deal with substantive matters, and the matter will proceed. Now, as judges, we work on jurisdiction. You don't give yourself jurisdiction that I'm supposed to handle this and that work. Jurisdiction is given to you. It's given to you. And in this case, I think our Constitution has been able to do this. And our main work is really to interpret laws and policies. And in this case, when we are talking about maternal and reproductive health and law, we are supposed to interpret policies and law so as to bring them in tandem or in line with the Constitution. We also do it to bring them in line with international instruments, because our Constitution allows us to do that. So that is our basic work. Now, if you don't have jurisdiction of a matter, you can't handle it. You will be challenged. And jurisdiction, as you all know, is a creature of statute. So the law must be able to say that. In this case, to me, the beginning point is the Article 126 of the Constitution, which gives both jurisdiction and independence to the courts. It gives jurisdiction to the courts. It says the power of the courts is derived from the people. So when you go to sit as a judge, you know that your authority is derived from all Ugandans. It's not derived from the appointing authority. Yes, the appointing authority may limit you at the time of appointment. But once you are appointed, the Constitution takes control. And then you have to serve the people. And that is the beginning of your independence. And the Constitution says you must be independent when doing your work. Because when you are dictating matters, there are people who are for and there are people who are against. There will always be a loser. There will always be a winner. In most times, there are times when you can have a draw, yes, but in most times, and there are interests. There are interests. Now, when these interests come into play, then there are attempts to see how a decision goes that direction or this direction. And that is when you call on your conscience and look at the Constitution, which gives you authority to be independent, to decide on matters. And I think, to me, that should be kept in the mind of every judge every time you handle a matter, any matter, whether small matter, whether it concerns what we are discussing, whether it's political or not. Now, rights, most of them are universal. We just put them in our Bill of Rights. But there are instances, there are countries who have tried to put up their own rights. They try to circumvent and say, if for example, you want to, you have a right to meet, and they say, no, you can't meet because you must meet only when you are 2 people. You can't meet when you are 20 people. It causes some security problem. Such ways of looking at rights, freedoms. Now, in my view, it's the duty of the courts to be able to bring back and really show that these rights are universal. Individual countries may have their own areas where they can be able to maybe set up policies and laws to address their local issues. But generally, we must adhere to universally accepted standards of enjoyment of human rights. Now, my own view is that matters of reproductive health are human rights issues. And in so being, they are under Chapter 4 of our Constitution, which provides for protection and promotion of these rights. It provides that rights are inherent and not granted by the state. I think that's important, again, for the courts to appreciate that the rights are inherent. They are not provided. So enjoying them, somebody should not come and say, we allowed you to hold elections. We allowed you to do this. No, we are entitled. We allowed you to have a meeting. No, you are entitled. The rights and freedoms should be enjoyed. And people should not say, I have allowed. Yes, the enabling environment should be there. The state should create the enabling environment, but the enjoyment cannot be said to be granted. Create an enabling environment. That's the duty. That's why you have elections, you win elections, and you say, I must provide security for all people. Having done that, you cannot again go ahead and say, now I allowed you to do ABCD. I allowed you to go to school. I allowed you to go to hospital. I've given, these are rights to the people. They're in the Constitution. So we should always keep in our mind that they are not granted by the state. And of course, there are many. And I was said, some countries have tried to go around it. Now the courts have the major responsibility of holding governments to account where they have failed to provide adequate reproductive and health care services. That the courts must come out and say, if your constitution says that you have a duty as a state, as a government, to provide maternal and health care services to all Ugandans, then you must do it. Now, many times when these issues come up in court, of course, there are arguments which are used by lawyers that you do it because you do it up to the extent which the resources of the country can allow you. They will say, look, we have done what is demonstrably, we have done what we are able to do, taking into account the resources we have. Now, that argument has been used many times and say, we don't have money. But some of us think that even the little money which is there in any system, in any government, in any organ of state, it should be used equitably. Use it equitably. Don't get resources and put 80% in security. And then you go to a hospital and you don't even have aspirin. Share out the resources, use them equitably. And I think the court should come out and tell government that, look, we appreciate you don't have a lot of money, but you have some money. Now that money, if it is 100%, fine, give security 50%, give education 30%, give also health 30%. But don't give health 5%, and then you give security 80%, and then you give education 5%. There must be equitable utilization of resources. And where government does not do so, there's no other person who can speak other than the courts. The courts will have to speak when people come. Again, there must be individuals, organizations like Sehud and others who must come to the courts and say this is the problem. And the courts will stand and look at the constitution, which has said the state must do the following, and be able to come up with a decision. Now, in arguing these cases of defending the state and so on, we've had instances, many instances where government lawyers will come and will put up all defenses. But in my own view, I think what we should be, and these people should be really officers of court, what we should all be looking at is not to defend your position as government or as an NGO, but the issue should be to look at what is happening in the population. If the population does not have medicines, if mothers are dying because of lack of simple reproductive health services, the lawyer should not be there to argue and say, no, you've come late, you've done this. The issue should be, are these services really being provided as a matter of fact? And go down to the ground and see. Go to the hospitals and see. I think we should start visiting locals even as courts, because a lot of locals is done when there is an issue of land. But when it comes to issues of maternal health, people do not even go to hospitals. The Constitutional Court has never stood up and said, let's go to Nakaseke Hospital, or let's go to Arua Hospital, or no. They are deciding matters, and affidavits are saying things are okay, the court, there's medicine, the doctors are there. The doctors are there, but they're asking for bribes. They are saying, look, I can't come to treat you because you have not put 200,000. You have not given any money to the doctor. The doctor stays at home and the mother dies. And it ends there. Those are areas where I think the courts have come up, and the Ugandan courts have done so. We've stood, I think the Constitutional Court has done that. We have issued structural interdicts to say, government, through Ministry of Health, do the following. What they have not done, and which I watch on TV every day, and I'm happy the minister is here, is to address the issue of medical workers. Every time I switch on my TV, I see medical interns are crying, and we are sitting at home, and they form a big percentage of our medical team. I think these are areas where government should be able to do something. Now they have also, again, state lawyers have also come with the issue to say that these issues of human rights are not justiciable, that they are not matters for the courts to decide, that these are matters which should be handled purely by the executive and the parliament. But we have rejected that argument. We've rejected it. I don't want to go into the details of the case, but we have rejected it. What I can confidently say is that the Uganda Constitutional Court has handled most of the issues and has not abdicated from its responsibility. When the issue of the political question rose up, it was raised by the state. Very unfortunately, the Constitutional Court, and I say unfortunately because it doesn't happen often, the court said, yeah, it's a political issue to provide the medicines and so on is a matter for the Ministry of Health, which should have, and the Constitutional Court bought into that argument. But I was happy when the Supreme Court came up and opened our eyes and said, look, these are not political issues. These are issues put in the Constitution. Provision of medicines to mothers and to children is not a political issue. It is an issue of human rights. And I think that was a good step that we got back to it. I just wanted to read what the judge said on that, if my eyes can say so. The judge in the Constitutional Court, and this was a lady justice in the Supreme Court saying this now. Constitutional Court, the Supreme Court sitting on appeal on a matter coming from the Constitutional Court. So it's an appellant matter to the Supreme Court on a constitutional matter. She said, with the greatest respect to the land justices of the Constitutional Court, I disagree with their reasoning and the conclusions they reached. The appellants, in paragraph 5 of their petition, contended that non-provision of basic indispensable health maternal commodities in government health facilities and the prudent and unethical behavior of health workers towards expectant mothers constituted acts and omissions which contravened and were inconsistent with the Constitution. Now she was trying to say, look, these are matters in the Constitution. The Constitutional case for us, we had said, no, these are political issues. And I think these are matters which we should really look into and understand them. So she said, no, these are constitutional issues. And she said that the unethical behavior of health workers. Now, you cannot call unethical behavior of doctors asking for bribes to be a political issue. It's a legal issue. It's a criminal issue. If the doctor asks for bribes, they should be prosecuted. But then people are saying, no, this is politics. You shouldn't touch it. Let it be handled politically. So she said this constituted violations of the Constitution. She went further and said appellants had set out the acts and omissions the government and maternal health workers had committed, which they alleged were inconsistent and in contravention of the Constitution, and said these were not political matters. So the political doctrine question that limits application of Uganda current constitutional order and only said it extends, it tries to stop courts looking into what goes on in the executive and in parliament. Because when you say this is a political matter, now the political doctrine question is saying when parliament is doing something, the courts should not go there. They are dealing with matters of politics. When the executive are doing something, it was a dangerous decision, but thank God it didn't stand. I will not go very far because I see time is running. Now, how do the courts then come in? When we find all this, we issue declarations in many times. We will say this law is in contravention of the Constitution and should be struck down. When people say don't gather because we have the Public Order and Management Act, we say no, Section 8 is unconstitutional. There's freedom in the Constitution, so we just strike down that law. And the good thing is that government has been complying. Whenever we say this law is unconstitutional, they have never come back. They have appealed, yes, and when the Supreme Court says no, it is unconstitutional, they have complied. The way they complied with the interdicts we issued in Sehud. So we issue declarations. We also give interdicts, structure interdicts. We think structure interdicts are useful because it keeps the court in constant touch with the government to see how implementation of the court orders is being done. So we will tell Minister of Health, we want you to put into your budget ABCD. We want Minister of Finance to increase the budget for Minister of Health. And please report back after 1 year. And when budgeting process comes, then the PS will come and say, yes, we have included. And these are the resources we think should go in. And I think we should appreciate government for that they have complied. Because in other countries, when you do that, the next day they cut the budget. I know in a neighboring country, when the elections came and people said, you see, you decided against us the other time, and now we have reduced your budget by this amount. Because that's one way of controlling activities. The court can also be controlled in that way. The government will say, the courts will say, we want to handle a session in Gulu, we want to handle a session in Bale. The Minister of Finance will look at that budget and say, this court, instead of 10 million, they give you 2 million. Then you can't go and handle the cases. They have controlled you without saying so, without telling you that you are in control. But they have controlled you. They have not given you money, so you can't decide on these cases. So financial independence is also important. And the courts must put it. Fortunately enough for us in Uganda, the enactment of the Administration of Judiciary Act solved that problem. I think now, taking into account the earnings of the country, the judiciary gets, I think, in my view, a fair share, which has enabled it to do its work. Not to the extent it should, but at least to a reasonable extent. So there's still a lot of work to be done, as has been noted by the keynote speaker, that there must be more interaction between civil society and the courts, interactions of this nature, where we all understand these rights, where we are all able to map out the way forward, where we are all able to appreciate that we must fast track some of these matters when they come before us, so that we can be able to serve our people. I thank you.
Thank you very much. Thank you very much, Honorable Justice Cheberoni. We are delving deeper and deeper and deeper. Cheborion, my apologies for massacring your name. Sincere apologies. So we're going to get into, I know some of us are dying to contribute. It was purposive that we need to create the appetite for us to have a conversation. So we're going to get into a short panel, and after the panel, have the conversation where, because some of these are weaved in a way that one session leads into another, we might preempt. After the panel, we're going to have a short conversation, and I'd like to invite the moderator of the panel to come and take their place. Haji Abdul Karim, please come and take your space, as well as invite the panelists, and then we can have a conversation after that.
Thank you very much, Salome, our moderator for today. Our dear chief guest, Honorable Norbert Mao, Your Excellence, Your Lord, Honorable Justice Chebron, all distinguished guests, protocol observed. So we want to thank our previous honorable speakers for the wonderful insights that have been shared, that are leading us into a short panel discussion. We appreciate that maternal health, reproductive health is a multi-sectoral and interdisciplinary kind of sector that we need to appreciate perspectives and experiences from other relevant institutions that have mandates to ensure that we have better and improved maternal health outcomes. On that note, we're going to have a few speakers who are also going to share with us a couple of insights from their mandates and disciplines. And then from that, like the moderator has mentioned, we will be opening up for a conversation. So ladies and gentlemen, allow me to welcome our first panelist for today. She's Honorable Bewona Josephine. She's the Honorable Member of Parliament for Bundibujo District, but also a member of the Health Committee and the HIV Committee, and most importantly, she's the chairperson of the Network of Women Ministers and MPs, Uganda chapter. We know the Parliament has a very critical role in ensuring that we have resources, we have legislations for improved maternal health. Honorable, you're most welcome to take your seat. We also know that we have other institutions like the National Population Council who have a mandate to ensure that we have very healthy populations. So before us, we have Dr. Betty Chadondo, who is the Director of Family Health at the National Population Council. Dr. Betty, you're welcome to take your seat. The Minister of Health, the lead in this conversation and their critical role, we'll have Dr. Miguel de Gracias, who is the Senior Medical Officer in Reproductive Health under the Ministry of Health. You're welcome to the panel to share perspectives from the ministry. And then the civil society who are behind the agenda to ensure that the citizen's voice is loud and clear before our policymakers, before our judiciary and other relevant bodies. We want to welcome Ms. Nachibu Kanul Musesi, who is the Deputy ED for Programs at the Center for Health, Human Rights and Development. We'll appreciate the importance of this panel before us, and we want to keep it short because usually sweet things are short. When you prolong the speech, we might lose it. So they are going to share with us very quick insights from their disciplines on how we are doing in terms of ensuring improved maternal and reproductive health in our country. I'll join the panelists and we begin the conversation. So, ladies and gentlemen, to begin with, Ms. Nachimu Kanol Musisi, when I see you, I remember a photo of you when you are heavy, carrying your firstborn by name's Faiha, and you're on the streets of Kampala, leading community members to courts of law to advocate for maternal health. And I know the Center for Health, Human Rights and Development has been behind these conversations on Petition 16. We just want to hear from you, your perspectives, your experiences, and what you think some of the milestones you have achieved since the case was ruled. Very brief, concise, to make it sweet for the audience also to contribute. Thank you very much.
Thank you so much, Karim, and glad to speak about a case that we litigated several years ago, which has since had several implications into this country. The case that we did litigate is the famous constitutional petition number 16 of 2011, the maternal health case that has been discussed already. But at the time of litigating it, we had several cases of women die. If we looked at statistics, when we filed this case, the UDHS, which is the Uganda Demographic and Health Survey statistics, indicated that 443 women out of 100,000 live births were dying at that time. What that meant is that out of 100,000 women that go to deliver, 443 die, and that was quite huge. We have since progressed in terms of progress. The UDHS that we have now of 2022 shows that the country has progressed to 189 out of 100,000 live births, and we should really commend the government and ourselves for the efforts that we've put in. By the time we got the ruling in 2020, the UDHS of 2016 indicated that we were at 336. And indeed, we want to think that the case that we filed has had an implication to the journey of maternal health in the country. So why we filed the case is because women were dying, and we felt that we were not doing much, and we wanted to test the role of the judiciary in having conversations around maternal health. And we went to court to seek for orders that by women dying the way they were dying in government health facilities because of lack of basic maternal health commodities, it was a violation of their constitutional rights. Now, at that time when we read the Constitution, we did not have that one act today. We don't have that one article that says you have a right to health in Uganda. We're reading it from other articles and objectives of the Constitution. But we know the Constitution has since been amended up to 8A that allows a reading of the objectives into the Constitution. But there were some good provisions on health there, including Article 33, that requires the government to protect women and their rights given their natural maternal functional role they play in society. So when we litigated, the journey was really long. We were in court in 2011. And at that time, Mr. Dr. Mulumba has already indicated that an objection was brought up. And indeed, the judges of the Constitutional Court agreed to the objection and indicated that the discussions that we are bringing are not discussions of the court, but they were discussions of other arms of government. So 2011, we lost. And we felt that, no, this was not correct because the issues that we are bringing before court are matters of constitutional interpretation. So we appealed in 2013. When we appealed, the Supreme Court upheld the appeal and sent back the case to the Constitutional Court. We had the trial in 2019, and in 2020, we got a judgment. So that judgment was ordering the government to prioritize and provide sufficient funds in the national budget for maternal health in the next financial year, which was 2020-2021. It also ordered the Minister of Health, or directed, to ensure that all staff who provide maternal health care services in Uganda are fully trained. It also ordered that all health centers are equipped within the next 2 years, 2 financial years, that is up to 2022, to ensure that maternal health services are provided, and directed the Minister of Health to compile and submit a copy to Parliament and a copy to court, a full audit report on the status of maternal health in the country, and awarded damages to the families that we worked with. The families are in Arua and in Mitian of the 2 ladies that had died. And that Attorney General was requested to submit a report at the end of the financial year 2020-2021 to court on progress of implementation. So I want to applaud the government that for all these so many orders, only one has not been implemented up to today. Only one. And I just want to say that Order 1 asks the government to prioritize allocation of funds in the financial year 2020-2021, but this was achieved in 2022-2023 when we read the budget allocation, and we noted that when it comes to the health sub-program, we had moved from 3.1 trillion in the financial year 2021-2022 to 3.7. Again, you see that even this financial year budget, I think the Capital Development Program, where Health Force has more money now, and we want to think that we have achieved in this way. And what we want to do is to ensure that maternal health becomes a priority as we see it today in the country. There's also a request to train staff who are providing services of maternal health. We saw the increment in the budget leading to the Ministry of Health training all staff that were providing reproductive, maternal, neonatal, and child and adolescent health services, and this closed the gap that we actually had at that time. But we continue to think that there's still more need, and I think the conversation around medical interns striking today comes back to hit us, because we know the value of the medical interns when it comes to provision of maternal health services. But at that time we achieved, and we hope that we will see. There was a requirement to submit a report to Parliament on maternal health audits. I really want to applaud the Ministry of Health, which did have a survey on maternal health audit report, which we have. The same has been presented to Parliament, and the same has been presented to court. And the first page of that report speaks to Petition 16, a summary of it, and indicating that court asked us to do this, and we are here to do it with very clear reasons as to why women die. So it's not surprising that today we see the local, maternal, neonatal, and weekly surveillance conversations happen in the country. At least on the WhatsApp groups that we are, you see that every week actually every day, almost a region meets to find out why a particular maternal death occurred and what should be done. And by the Ministry of Health picking it up, I think every Thursday, to have a conversation on what we should be doing, we applaud ourselves and think that we can actually do better in terms of this. I indicated earlier that only one is pending. The families that we litigated with in Metiana are very poor families, Metiana and Arua. When you look at Jaja Roda of Metiana, she's very old. She has moved the journey of court for more than 9 years. It is just fair that her award of, and the one of Arua, a gentleman called Nziko Valente, it's just fair that their 155 million that was awarded is actually provided. Of course, these have been engaged. It is up to this week that the team in Arua has written back to say that the PS is responsible for this, and therefore we have written to the PS at the Ministry of Health to indicate that since they take on the regional referral hospital, we need to facilitate these teams. We are yet to hear from Metiana, but we want to think that they will actually do work. So in addition, I think this particular case brought us all together, because what we were speaking about were issues that concern us all. Because it's either you or your wife or your sister or your mother. So it was an issue of public interest. And I'm certain that the conversation that we're having then is a conversation that touched us all. So we want to think that, again, no woman should die while giving birth. Thank you.
Thank you very much, Noor. I didn't allocate seats, but I think it was by design that Minister of Health comes after. So from what we've heard from Noor, what more initiatives has the ministry put in place? Where do you find the gaps? And in terms of stakeholder engagement, where do you think other key players can come in?
Thank you very much, Abdul Karim. And thank you to my previous panelist. I think she has set a good stage for this discussion. And like we have already had, this petition 16 has provided a good basis and foundation for the Ministry of Health to work on accelerating the reduction in maternal mortality. And it has given us a good story to learn that legal advocacy can actually contribute to the reduction in maternal mortality. So based on those 4 impacts that we received from petition 16 around increasing budgeting for maternal health, capacity for health workers, and infrastructure, a lot of processes have been put in place by the Ministry of Health, and I would like to mention some of them. One being working on the key strategies and guidelines to improve service delivery for maternal and newborn health in the country. So from the time this judgment was passed out, we've been able to work on several key strategies, including the RMNCH sharpened plan, which was able to give us the strategic direction that the country should take, and also identify the different key areas and priorities that need to be addressed in order to improve maternal and newborn survival in the country. Plus also several key clinical guidelines. We've worked on the essential maternal and newborn clinical guidelines, the newborn clinical guidelines that provide clinical reference to our frontline health workers as they are caring for these mothers and newborns during the process of childbirth. The other important area is making sure that you have commodities available in our facilities. But most importantly, we've worked on ensuring that we introduce and scale up new technologies and new commodities that are key in ensuring that mothers survive. Our mothers have continued to die from bleeding, and in this we have worked to introduce specific drugs across the country, which actually are more effective in seeing that these mothers survive, plus also the newborns. We have introduced drugs like IV caffeine citrate for the newborns and carbetocin for the mothers, and we hope that this has resulted in the reduction that we have already talked about. The other area, of course, has been in continuous advocacy for health financing, and this has already been mentioned. And just to point out that we have already seen that the government has increased salaries for health workers, but also this financial loan, we have noticed that the resources available for commodities, we're able to get more funds to a tune of at least 72 billions to support procurement of more health commodities, and I'd like to appreciate Parliament for that support. The other area, of course, is in the audits. As Minister of Health and specifically through the Reproductive and Child Health Department, we have scaled up the process of counting and accounting for every death of a mother and newborn through the maternal and perinatal death surveillance and review. We do this from the national level up to the lowest facility, whereby we know each mother who has died and why they have died, and also engage our health workers and facilities to see that they audit these deaths and focus on the deaths even for both the medical issues but also the greater determinants of why these mothers are dying. Looking at what we call the 3 delays, the delays at home, the delays in the reaching the facility, but also most importantly the issues around the delays in the health facility. And we have used this process as an entry into improving quality of care for mothers, because we are able to identify the gaps in care and design robust systems of how we can improve. This mechanism has enabled us to improve service delivery in all aspects, right from leadership. We have used evidence generated from these reviews to address leadership challenges in commodity availability, human resource, and the others. So the other aspect is around infrastructure and equipment. Again, with government, we've been able, over the last years, we've been able to support establishment of several EMOC facilities, where we know that at least for all our health center force, 86% are able to conduct a cesarean section. This is a very great improvement from the time when this petition was passed. We were standing at less than 70%. So we know that cesarean sections are key in ensuring survival for mothers and children. But of course, plus blood transfusion, now we are standing at 52%, which is still an essential intervention in ensuring survival for mothers during this process. Something on training has been mentioned about. We have defined standard packages for training of our health workers in provision of emergency obstetric and newborn care, and several efforts are in place to see that all our health workers are competent enough to see that they provide evidence-based care. And finally, in what we are doing is what we call respectful maternity care, in addressing the issues around ethics and professionalism, borrowing from the quality of care standards from the World Health Organization. We have adopted national guidelines for respectful maternity care to see that all our health workers attend to these mothers with dignity and respect, but also seeing that as we are doing supervision and as we are doing these audits, the component of respect and dignity during the process of providing care is adhered to. In terms of gaps, of course, despite all those interventions that are in place, we still have challenges with human resource, both numbers, but also the critical staff. We have challenges with anesthetic officers who are very key in ensuring that we have emergency operations done. This should be deployed in adequate numbers, but also equitable deployments, even in the hard-to-reach areas. There are still challenges with commodity availability, essential commodities. On so many occasions, we've had issues around stockouts, but also a delayed supply of these commodities. Still challenges around the high numbers of newborns dying in our country. And for those of us who have followed the weekly annual maternal and perinatal death surveillance and review, you know these numbers still are abnormally high. But also the high teenage pregnancy rate, standing at 24%. We know that currently, of all the mothers dying in our country, 10% of these are teenagers. So we think this high number is greatly contributing to the mortality we have. But also beyond that numbers who are dying, the effects of teenage pregnancy go beyond the deaths. A lot of them suffer medical complications like obstetric fistulas, which again put a very high burden on the system, but also the other social issues around the pregnancy like school dropouts. So we think we need to still do a lot in order to contribute to this reduction. Where we need more support from stakeholders and partners, one is as continuous advocacy for the gaps that we have already seen in human resource, in adolescent health and teenage pregnancies. We still need to ensure that we advocate more for these key areas. Number 2, in community engagements, we know that a lot of maternal health outcomes are greatly determined by the practices and behaviors that we see at the communities, the health-seeking behaviors, the need for our mothers to come early enough for antenatal. We recently saw in the UDHS report that despite the fact that over 90% of our mothers are attending antenatal, but less than 30% attend in the first trimester. Yet we know that for us to effectively intervene and have a positive outcome, we should have these mothers attend antenatal timely. And also the other number of mothers who are delivering outside the health facilities. We know that 14% are still delivering outside the health facilities. So these need to be reached out to see that they deliver in our facilities in order to be able to receive adequate care for survival. Thank you very much.
Thank you very much, Dr. Migade and the Minister of Health for those great initiatives. It's quite a mouthful, but also resource intense. You mentioned Parliament a couple of times in your engagements, and we know that Honorable Bewona was also among the champions who are behind our campaign for maternal health. But also we know that the Health Committee of Parliament has a critical role in ensuring that we get more resources for our health sector budget, but also in terms of your mandate as custodians for our legislations. How do we ensure that the right to health broadly, but also the right to maternal health is achieved through the committees you serve?
Thank you so much, and good evening, viewers, once again. Of course, I've already been introduced, but in addition to that, I sit on the Health Committee. I've sat on the Health Committee, I think, for the last 7 years. And I'm happy to inform you that some of the things we really advocate for, Ministry of Health, government has been able to fulfill. Some of the things have been mentioned by the representative from Ministry of Health, and we are not yet there where we want to be, but at least we are trying. We know we still have, though according to the presenters who presented first, we still have challenges. We still have more maternal death. He has just mentioned that some of them maybe could be contributed because of the young age. It's now like, it's the whole country, it's all over, the teenage pregnancies. We cannot say it's not a contributing factor. But as members of Parliament, for us, we are there to oversee government policies, programs, and also to allocate monies. Our budget allocations sometimes have been cut off. So sometimes those challenges come in when we allocate some monies to different entities, but the Ministry of Finance is not able to provide that money. So we still have those challenges. But as government, I know it is also trying so much to make sure it fulfills its roles and to make sure maternal health is improved at all levels. Not only maternal, also the perinatal and infant. Now, for us as Parliament, we cannot work alone. Of course, we work with different entities. We work with all of you. It's a collective responsibility if we are to reduce these maternal deaths. Now, when I was listening to Dr. Mulumba, the first story he gave was so touching. I am a midwife myself, but it was so touching. And up to now, even though I'm in Parliament, I still deliver mothers. Yeah, we are let down sometimes by our health workers. They have mentioned all these things. And I happen to come across a mother has come to the hospital, nobody to attend to, and I just swing to action and I make sure I deliver that mother. Now, suppose I'm not there at that right time. What can happen? Yeah, the outcome will not be good. So the story was so touching. I observed all of you, the faces, you were so quiet because these are our mothers, these are our sisters, these are our daughters. Yeah, these are our wives. You know, you might be somewhere very far at work and such incidents can happen to all of us. So, as much as we are allocating resources, as much as we are doing our oversight work, we are legislating, we are making policies, but still we have those challenges in our communities, in our health settings, which let all of us down, and which let the government down, by the way. We have enhanced salaries of health workers, but these are the health workers who continue to extort money from patients. I have seen, and we have arrested some of them, where the services are free, it's a public facility, but the doctor will continue to ask for money to carry out an operation. That is so bad. So, we would not be here listening to all these cases which have occurred in the country, and these are the cases who get the opportunity to be heard. But there are so many cases out there, and things just end like that. Mothers are continuing to die. Sometimes it's the responsibilities of we hold account the health workers, but there's no one to follow up. So I don't know how we are going to do it, but we should not stop and wait for these cases which are reported. Maybe we should, Ministry of Health, help us. We go down on ground to look for those other cases which don't have the capacity of reporting or of being heard of. Health is a right, the right from the Constitution, like we have had, and sometimes these rights have issues, and that's when the courts come in. You know, the courts will come in because of our negligences sometimes. So we would like to hear these cases reducing. So that means government will have to intervene, and all of us as stakeholders will have to intervene. And then some of the cultures also have let us down. You know, some cultures believe that if you don't produce 10 children, like some cultures I know, you have to produce 10 children so that you're slaughtered a goat to celebrate that you have produced 10 children. Yeah, some women will feel, I want that goat, but not not minding about what will happen. Yeah, the uterine ruptures sometimes you know, the doctors who are here and other health workers, you know, sometimes due to the many more deliveries you continue having, and then you lose the elasticity, and then you can have some of those issues happening. So, as Parliament, we have the capacity to act, to question, and to propose legislation and policy, even to summon the responsible ministers to come and explain. Yes, so we are not working alone. My sister was saying she's happy 2020, 2023, what they wanted was implemented. But also as health committee, we also push so much for those things to happen. So we all want to reduce the maternal mortality cases. We don't want to have many cases. We don't want to have people challenging government, leading to courts of law. We all want justice, and we want equity in all the service delivery. When government has introduced upgrading of health center 2s to 3s, the main component is having a maternity unit at that facility. That means even the traditional birth attendants have reduced delivering our mothers, because this facility, Health Center 3, is nearer to the community. So a mother can be able to deliver there. We have challenges of human resource. Maybe that one can continue to be handled so that even when the ministry is constructing for us those health facilities, they shouldn't be only structures, but you should equip them with equipment, the medicines and supplies, and then even the human resource itself. There is a scarcity or low human resource in the areas of anesthetical assistance. I don't know whether, I'm not so sure, but some time back, they used to complain of they go for those courses, but when they come back, they still stay on the same salary. Like they are not recognized and given a good salary as anesthetical officers. So many people are not interested to go for that course. Then the other thing we are requesting Ministry of Health, at least every health center it should have an ultrasound scan. So that, and of course, many people will train in those areas so that they can help these mothers to identify the risk mothers earlier, so that some of the things don't come up at the end when they are delivering. Then emphasis also should be put on adolescent-friendly corners in all the health facilities. Since we are now having so many teenage pregnancies, we can have those adolescent-friendly corners so that these young ones are helped out when they come to seek health care in some of our facilities. As members of parliament, we shall continue with advocacy. We are always having so many platforms. We can speak anywhere. Even at a burial, people are crying, but for you are there speaking. Because you will not have a chance of getting maybe such a big gathering. So sometimes we pass on this information when we get those forums. So courts provide forum for the society, fine, you are helping us, but we would not like to have so many cases flooding your courts. No, these things should be handled at community level with government, with all of us, so that we avoid such scenarios. I thank you.
Thank you very much, Honorable. I like how you are emphasizing the role of a multi-sector approach, and we think it's the way to go. Dr. Betty, you've been a champion of safe motherhood. We've been moving with you along so many campaigns, but also we appreciate the role of the National Population Council, and we know we cannot just have healthy populations without healthy mothers. So we want to understand from your perspectives from the council what kind of initiatives and interventions are in place to ensure we achieve good improved maternal health outcomes, but also reproductive justice.
Thank you very much, Abdul Karim, and thank you, Afia Naki, for giving National Population Council the opportunity to speak on the rights of women, the rights of children, but overall sexual reproductive health. The mission of a National Population Council is to improve the quality of life of the people of Uganda. It is not just specific for health, but the quality of life of the people of Uganda, and specifically by influencing government policies and programs to address population patterns and trends in a sustainable and inclusive manner. So for us as the National Population Council, health matters, but all the other aspects of economic development are very pertinent to us. So in terms of improving and contributing to improved maternal and reproductive health, I'll specifically talk about 3 things. I had 5, but the 2 have been repeatedly talked about by the previous speakers. But before I speak, I'll appreciate I actually don't know how to address him, because for a long time I have always called him Director General. But anyway, he's Director General Emeritus, because he has mentored us to be able to speak and express ourselves in a manner that people understand us. But what do we do? Number one, we do undertake policy dialogues. And what are these policy dialogues for? For us, policy dialogues we undertake with decision and policy makers. And I'm happy that a number of you are saying that you have been working with us, engaging with us, but I'll focus on policy dialogues that we have undertaken with our members of parliament, but also the local governments, to ensure that the sexual reproductive health issues have a limelight and are integrated in the plans at both national and also local government level. And when we do undertake these dialogues, we have realized that they help us to close the gap in access to quality sexual reproductive health, and maternal health is one of these. And what we have realized is increased awareness of our sexual reproductive health gaps among policy and decision makers. You have clearly heard, when we engage with members of parliament, today we have a technical member of parliament who knows these issues very well because she's a midwife. But not all members of parliament are at the same level. So when you engage with members of parliament and articulate these issues, it helps them appreciate and also try to lobby for either financing, or they even use that information that we give them to engage within the communities. But also the dialogues improve the discussion on how to effectively address the underlying systemic and social challenges to sexual and reproductive health. And also 3, they promote accountability and compliance with the laws and policies of our government. So when we engage, we increase awareness, but we increase accountability for these issues. And finally, we do try and see that discussions around how to effectively address these issues are undertaken. Number 2, we advocate. When we advocate with members of parliament, and we have done a lot of advocacy with the network of Africa women ministers and parliamentarians, and I want to applaud our DG Emeritus, because I think there was a time the network was very strong and powerful. And at a certain point in time, they even blocked passing of budget if maternal health was not given due consideration. So for us, this advocacy with members of parliament has been very, influential in the kind of engagements that we undertake. And we also know that working with civil society organizations, we have tried to track the budgets for sexual reproductive health, for family planning, and we use that evidence to engage parliament on where are the gaps. Are the gaps in commodities? Are the gaps in human resources? Where are the gaps up to the local government level, so that we engage from an informed point of view? And because of that advocacy, we have seen an increase, of course, in the budget, in the commodities, but also in ensuring that human resources for health to improve maternal and child health are addressed. And then finally, we engage in community dialogues. And we have engaged in creating awareness on the interlinkages of sexual reproductive health, family planning with development. I told you, for us, our effort is to improve quality of life. So we don't stop at health. We want to see a transformed society that is really transformed in terms of its socio-economic development. So we conduct community dialogues, and participants are usually from the community. So you can imagine different segments of a community are engaged. And I'm also happy to report we have held a number of community dialogues, which we have codenamed Safe Motherhood Conferences in the past, with our National Goodwill Ambassadors, the First Lady of the Republic of Uganda, and also the Minister of Education and Sports currently. We held a number of dialogues in different regions across the country, and some of you, especially Dr. Sentumbo, were part of these dialogues to kind of increase understanding of sexual reproductive health on development. If you have many children, how is this going to impact on your livelihood? If you have fewer children, how is this going to help you be able to take your children to school? We have had these dialogues in the communities, and they have helped us promote safe motherhood, but also they have also helped us ensure that communities start appreciating the role of family planning in development. I think I'll stop here. Oh, I had to emphasize, but this has also, I wanted to skip it, the issue of teenage pregnancy. In not long ago, maybe 3 years ago, the National Population Council has started working with the parishes, and we have established in some of our districts, because of our resources, what we call parish teenage pregnancy prevention committees. The aim of why we established the parish teenage pregnancy prevention committees, we thought we would leverage on the parish development model to engage the communities on the importance of not getting these young girls getting married early, but also getting pregnant, because it doesn't help communities seeing that when you're speaking to them, they will say poverty is high. And then when you ask them, why is poverty high? Because girls are not going to school. Why are they not going to school? You go through that, you know, the cause of a problem. They know the cause of a problem, but they are not addressing it. So we thought that this parish development model is a powerful tool. It is an opportunity for us to address issues of early marriages and teenage pregnancies at that level. And I'm not sure whether we have yielded good results yet, but we hope that we shall continue engaging the communities at the parish level in ensuring that we address the issues of teenage pregnancy prevention. And I submit.
Thank you very much, Dr. Betty, and the National Population Council at large. Ladies and gentlemen, our panelists, I'm sure they had a lot to share, but because of time, I want to request we close the panel here, and then I hand it back to the moderator for the day to lead us into the discussion. Join me to applaud our panelists for today for the very insightful discussions. Thank you very much. We may have our seats. Over to you, Sorome.
Thank you very much. I hope you've managed to get some tea or coffee. Do we have some sugar in our systems? Tea, coffee, bites. If you haven't or were shy when your neighbor got some, please don't feel shy. We're here to promote the right to life, and food is one of the things that is central to the right to life. So we're now going to get into the last section, which is actually the most juiciest section, which is climaxing a lot of learning that we've gotten here. We see we are all contributing in one or the other, and now we're going to get into tying it all up. Before we tie it all up, I have the singular honor and pleasure of presenting a lot of work that has been done. One of the challenges we've had around pushing issues like the right to health, maternal health, reproductive health, sexual and reproductive health and rights, even if it's around human rights, we have always been blamed it is a Western discourse. We've always had to explain ourselves how African or how indigenous the right to be is. So there is 3 knowledge products that AHAKI has invested itself into to produce to allow us to really understand and feed into the theme of today. Advancing courts, the use of courts in advancing maternal and reproductive health. And these 3 publications, after I read them out, they will be officially cut by our chief guest, and then he gives us his very powerful message as the Minister of Justice and Constitutional Affairs. when we see the speeches that were made by everybody, there are some things that he has to respond to. But we are very confident that Honorable Mao is going to respond to them, whether the issues are in their speech or not. And then after that, we're going to have the closing and then have a cocktail so that we can cusp it all up. So the first publication is called Beyond Reproductive Rights, Critical Reflections on Reproductive Justice in Eastern and Southern Africa. And this is a relatively new publication. It is a 2024 publication. Then the next publication, people in Ahaki were not sleeping. It's a July 2024 publication. It is using reproductive justice to litigate the right to have a child in the African region with a focus on maternal mortality. When you get your copies of these publications, either you would like to get the physical ones or the ones that are online, you're going to realize that a number of people have invested their thought into this. The kind of people that have written the publications are people that you would admire to be with, but then you're going to have them in a publication. How powerful is that? Then, the most recent publication, now you see even the sizes are getting bigger. Do you see how exciting it is? The most recent publication is called Towards a Reproductive Justice Network Framework for Africa. Some of you here have talked about the framework. So, this is talking about how do we get there, and also it is a new publication. It is an August 2024 publication. In other words, we are in August. Today is 8th August. Probably it was published yesterday. How lucky we are to have it. So without much ado, I'd like to take the honor to invite Honorable Robert Mao, the Minister of Justice and Constitutional Affairs, to come and do the official dissemination of the publications and then give us his remarks as the guest of honor. Please welcome Honorable Mao to the podium.
Thank you very much, our Chief Moderator. Ambassador, Deputy Ambassador from the Royal Netherlands Embassy, my Lord Justice Cheborion, let me say all the dignitaries in your various capacities. I'm rarely intimidated by any audience, but today I must admit that I feel like I'm in hostile territory. You know, doctors, activists. This is not a field in which I'm very familiar. Fortunately, I'm a lawyer. I'm not talking about being learned, but lawyers don't give answers, they give replies. So don't expect any answers from me, but you'll get a lot of replies. I had prepared a beautiful speech here, but listening to you now, I feel as if it is irrelevant. Truly, as the theme says, the role of the judiciary. So I made a few notes in an attempt not to bore you with a bureaucratic speech. I think we should start with what we all aspire for. That is the really common sense. What do we all want? I have written down 3: health, education, livelihood. We want to be healthy. We want to be educated to get some skills and knowledge. We also have the aspiration to have some means of sustenance. So when we talk about the roles of the courts of law, of course we are talking about the judiciary. And then when you remove that veil of the word judiciary, then you find human beings called judges. Now, judges have world views. They have the way they look at the world. There are two things. One is called self-conception, how you see yourself. The other one is called cosmoconception, how you see the world. Actually, judges are not neutral. Let me just tell you straight that if in case you have ever had illusions that judges are neutral, hear it from the Minister of Justice that judges are not neutral. They have a point of view. They have a stand. Judges are impartial, which simply means they really don't have an interest in your particular dispute with another person or in your particular dispute over the interpretation of the Constitution, but they have their point of view. You yourselves have been talking about something, but you have not called it by its proper name. Power. All of you are talking about power. His Lordship talked about how the executive can squeeze the judiciary by denying them money. Now, that is power, of course. The judiciary also has power. They can send you back to vote again. They can remove you from parliament. And many other things. And of course, the parliament can change laws. Now, I thought we need to give all our discussion a context. And the first context is that we need a kind of philosophy. So even if you forget everything that I'm going to say, from listening to you, I have concluded as follows. Things are not as bad as they have been. Thanks to you who are here. So the things are not as bad. We were in a worse place. We are in a much better place. And in this room are people who, as they say, spat on their hands, held the plow, and push things forward. The second context, when we talk about the courts of law and those who sit in the courts of law, is that we need to reconcile extremes. Somebody was hinting here about Roe versus Wade. That is the famous case which declared that abortion is part of a woman's right to privacy, and therefore no government can interfere with that right. And it stood for ages and ages. Meanwhile, under the cover of the noise of politics, the Supreme Court of America was changing its color. until a dominant force took charge of it. Now, I hope that proves to you my thesis that judges have a world view. The Constitution of America is the same. So what has changed? What has changed is the people who tell you what it means. So these judges are the ones who tell us what the law actually means. Unfortunately, laws are written in such a language that people must sit for hours and hours and lawyers must argue just to tell us what it means. So we have extremes. There's a lady now called Saint Mother Teresa. One day she appeared during the National Prayer Breakfast, which is annually organized in January by the United States Congress. That meeting is normally a gathering of so-called evangelical Christians. And since Mother Teresa is Catholic, and Catholics are known to be more conservative than not, the Republicans, who are known to be conservatives, relaxed and said, yes, our woman, give it to them. So she starts her speech. She's very soft-spoken. She says, to those who carry out abortion, you have no right to kill babies, you don't give life, therefore you cannot take it. And everybody is saying, give it to them, Mama. The Republicans are so excited. Then she continues, and those of you who think that you are ordained as the moral police in the United States of America and elsewhere, when you see an abortion clinic, you go and throw bombs at it, you are also committing murder. Stop it. Now, so what was she addressing? She was addressing extremes. She was saying, well, you may think you are appointed by God to protect life, so you call yourselves pro-life. So she blasted the pro-life and also blasted the pro-choice. That brings me to the thorny topic of law and morality. For all the reading I've done in my life, I know the definition of law, but I have not yet found a proper definition of morality. I know what is not moral. So that takes us into the province of legal justice and moral justice. Those who pronounce themselves in Roe versus Wade were really belonging to the school of thought of legal justice. They said, give justice to those women whose lives may be in danger and they need to terminate a pregnancy, so that instead of having 2 funerals, we may have 1. Now, the ones in the Supreme Court now believe in moral justice. The nearest definition of morality I can give is a path of duty prescribed by God to man. I hear some people receive messages from God. How often have you heard people saying, God has told me? Of course, I know the Bible is a message which was left and it is on record and is not subject to amendment. So let me also tell you another thing after telling you that judges are not neutral, that the law can stop you from being bad, but the law cannot compel you to be good. That is a dilemma we are still dealing with. Incidentally, that is also my defense of morality. Now, morality is really a personal affair. So the law can tell you, in case you do anything bad, we know how we are going to treat you. But the law cannot say, be good and then enforce that aspiration. So there is a role for the law, and there is also a role for morality. You also spoke here about those who go around saying, I could do a lot of bad things, so please thank me for not doing the bad things I'm capable of doing. To expect to be thanked for not doing a bad thing is the most primitive expression of power. So, if I have a gun, I cannot say, all of you should now kneel down to thank me and say, you know, Mao could have shot all of us dead. Thanks be to God, we have such a man like Mao. But what good have I done? Because good and bad are well known. Anybody can be bad. So when you restrain yourself from doing the bad things you are capable of doing, that's no ground for applause. Now to the direct replies that I promised. It is the duty of the state to create the conditions in which the things you are advocating for can be done, and not to undermine those conditions. I was born at home. I'm not one of those who was born in a hospital. The state should not stand in the way of those who are teaching our people how to be responsible with their bodies. Otherwise, people will go into experiments. In our culture, in the North, even if you're a little boy of 7, you are allowed to taste alcohol. Then you get to know what it tastes like. And then you are not super excited about it. You then can be responsible. From the age of about 16, 17, your parents know generally that perhaps you are beginning to take notice of your female classmates and those you share the roads with. So the culture dictates that you build yourself a small hut. And the parents, of course, will pretend that they are not aware of your intentions or the kind of people you want to host. But it is generally assumed that the older members of society will talk to you about the changes that you are undergoing. I understand here in Buganda they have people called Sengas. Of course, they have now vulgarized it too much on TikTok. But I do believe that the original intention was to ensure that your awareness takes the correct direction because you can get awareness but in the wrong direction. So as a result, you end up squandering your life. In most schools, there used to be those they call senior woman leader. I don't know why our system emphasized more the need to talk to girls than to boys. There was always that person called the senior woman leader. So education in the field of sexual and reproductive health is very important. The things that you have been taking to court, those are the things that keep people awake. We have got so many rights in our constitution, and there are violations. So by pronouncing itself, the Constitutional Court generally opened a new chapter for Uganda. So we are grateful that the Parliament of Uganda, with the support of the executive, particularly the president, has really empowered the judiciary, at least financially. Occasionally, the state does things which undermine judicial authority, but in this field of adjudicating disputes over the Constitution, we generally accept. We are also humble people. When we lose cases, you just humble yourself and you let it pass. It's not nice to lose a case. We have been losing a lot of cases. The Computer Misuse Act, lots of this provision were thrown down by the Honorable Justice Chiburion's court. Even the famous Anti-Homosexuality Act has been reshaped. We don't know what will happen when it reaches the Supreme Court. Though the world is already judging us, they don't know that the legislative loop has not yet closed. Until the final court has pronounced itself, we cannot say for sure what is now the law of the land. So we are still waiting. The police were also tamed. They also ate their humble pie. Those provisions were thrown out. And I want to assure you that in response to what the court did, now we are working on regulations under the Public Order Management Act to reduce even further the discretion of the police. So we are not always there plotting evil against citizens. We are also plotting good things. We also accept, because in any case, we also need those laws. In this world, you never know. A great friend of mine, who was a strong advocate of the Public Order Management Act, found himself in direct collision with that law during presidential elections. I will not mention the name, but it is a very famous name. So, now the same applies to, of course, government will not want to say, we did this because we were taken to court. You know, you are like a head of a household. When you are wrong, you don't admit that you are wrong, but you do the right thing without admitting. Then you say, I've been thinking about doing this for a very long time. Now is the time to do it. So Nakaseke Hospital definitely was part of the great vision of the national resistance movement, as opposed to your court case. This is one thing you need to know. I hope this assures you that we are not deaf. We actually listen. We do listen to these things. You saw what happened in that hospital after Dr. Besigye visited in which district was that? Yes. So, in conclusion, the struggle continues. Just continue the struggle. The beauty of your struggle is that you really have very strong arguments. There are those who are easy to dismiss. I want to state here that your group is not easy to dismiss. There are groups that can be very easily dismissed. Either they can be accused of being power hungry, but I lived through your reports. I listened to Dr. Mulumba, and I've requested for a copy of his paper. I do believe that the courts are also now aware, at the risk of offending some people. You know, there are those busybodies who are always in court, suing for one thing or another. I'm sure when Justice Cheborion sees such people, he just relaxes. He knows, well, this is a featherweight really in terms of the case. But I'm sure when this group that went in constitutional petition number 16, when they come back to court, you have to pay attention, because you know they are really a serious group. So today, we come to validate your work. Government cannot do everything. Organized citizens can be key pivots of social reform. Everywhere in the world, even the French Revolution started with the women marching. They are not talked about much, but it was the women who were marching. The civil rights, the spark of the civil rights movement in America was with just one woman who refused to change seats. She was told, "Ma'am, you have to leave the front of the bus, go to the back, because that's where black people belong." And she said, "Sir, I've been working the whole day for my family. My feet are tired. I'm not going to move." So they arrested her. The rest, as they say, is history. Of course, some people seek social reform through other means. In 1981, a group collected 27 guns, and again, the rest is history. You cannot stop determined citizens who want change, one way or the other. So, I'm very, very grateful to Afya Nahaki. I have to confess, I had never heard of that organization. I'm not going to be like those ministers who will say, "I have appreciated their work for a long time," and so on and so forth. I only got to know about it when the chief organizer, Ms. Kashilingi, contacted me through her brother, because definitely I'd also never met her. So the brother called me and said, "There is some exciting thing going around. You have been losing cases, and now you better go and meet the people who have been causing you torment." So I immediately said, "Yes, let me find out whether I don't have to spend too long in Parliament, then I will come." Let me tell you a secret. Governments want to associate themselves with good things. Now, this is a good thing. We definitely would love to associate ourselves with it. And to the judiciary, yesterday I had a long conversation with the Attorney General, and we generally agreed that, look, we need to have a conversation with the journalists and the activists and say, leave the judiciary out of our quarrel. Because once you are also dragged to our level, we will not have a society left. Feel free to insult President Museveni using all the superlatives in the dictionary version you use, from Michael West to Webster's. You can insult Parliament the way you want. For us, we are fair game. First and foremost, you must know the distinction between we, the politicians, and the judges. You need certain skills to be a judge. To be a minister or a parliamentarian, you really need just political skills. I'm not a minister of justice. I was not interviewed on qualifications of how to be a minister of justice. It all depends on political skill. So we are fair game. We can roll with the... But let's please protect our judiciary. They are not gods. They are not perfect. But the same way that, you know, the children of Noah protected their father. Sometimes they are also naked. It is okay. But let's move slowly and cover them. And when the alcohol will get finished from their heads, and life continues, and then we don't talk about it. So I wanted to assure the judiciary through the Honorable Justice Cheborion that really we need to tell our citizens to not to attack those who don't have the same platforms that we have. Judges don't go to talk shows. They don't address press conferences to reply to us. And even the Chief Justice, who was under attack for long, we eventually went to him and said, you know, we are here. If there is anybody who wants to roll in the mud, we will accompany them happily. And we roll in the mud. So protecting the judiciary from what now is known as radical rudeness. I was told that that's the technical name, that you academics have now found a name for the things going on social media. That is called radical rudeness. It is a rudeness of the most extreme kind. So let us protect our judiciary from the radical rudeness. I want to assure you, as far as we are concerned, we are alive to the culture war that is going on in the world. And that culture war is not new. It dates back to the days when women were not supposed to eat chicken. Can you imagine how far we have come? My grandmother could cook chicken. She's supposed to put the salt to taste exactly to the desired palate that the men have, but she's not supposed to taste it. Women were not supposed to wear trousers. All those things were there. You can find these culture wars in books like Song of Lawino. You can find it in Ngugi wa Thiong'o's book, The River Between. We have a culture war among the Sabine. There are those who believe that female circumcision is a right. And there are also women who insist that, you know, why are you denying me that privilege of practicing what my grandmothers practiced? So, fortunately, I think as of this afternoon, I don't think there is any spot in Kampala or Uganda maybe which has a higher concentration of intellect as of now, other than this room here. So you can appreciate, let us not oversimplify these things. They are quite complex. I want to pledge that if there are some laws that you would think should be reformed, let's have a conversation. We have our boardroom. The Ministry of Justice is open. We will be happy to meet you, and you tell us that the following laws need to change. You have definitely challenged us that we are implementing archaic laws. Naturally, government does not want to do anything outside the law. So even if the law is a colonial law, we will look for it and wave it to achieve our purposes. The president was stuck with the population. Fortunately, Ugandans were quite disciplined during COVID-19. Contrary to what some people in government say, Ugandan citizens are actually very disciplined. People stayed home. All of us stayed home. And I think we have never been thanked enough for it. So with that, we hope we will have another forum to discuss these issues that divide us. We live in a very polarized world today, and the polarization is everywhere. So I want to thank the generations of academics, intellectuals, researchers, activists who are here, and people who are committed to the vocation of medicine and public health, like the Honorable Member of Parliament for Bundibujo. I had never known that she still practices. Definitely, I was a beneficiary. Mine, I don't think was really a midwife. I think mine was these people who are called traditional birth attendants. My grandmother was one of them. So I'm very grateful to see this. And of course, the Director General, you have retired with that office the way I retired with the title of chairman from Gulu. I just left the office with the title. So I don't even feel like can call you Director General Emeritus. You're just Director General. So, and it is okay. The way I'm Chairman Mao, the way I go, wherever I go. So we are very grateful that you still continue to sit among the younger generation. And to the group of Ms. Kashilingi, let us make this advocacy now continent-wide. Let us broaden it even to East Africa. And those who continue to support this initiative, come to the Ministry of Justice. There are new laws, by the way, the new edition of the laws of Uganda. Come and visit the Attorney General. You will definitely have your copy so that you know which laws need to be changed. The subsidiary legislation will soon come. I don't know whether you had invited people from the Ministry of Health, but on Monday during Cabinet, I will tell the ministers from the Ministry of Health that, you know, you really missed something beautiful. And I basked in the limelight and met people I had never met before. Thank you so much for listening to me. Let me now go and perform that ritual. What did you call it? Dissemination. Okay. Please. You know, Solomon went to school, the same school with my wife. So now I'm a honorary OG. I'm an old girl of Trinity College Nabingo. I'm sure the Deputy Ambassador is supposed to come. The perennial Director General has to join us. Mheshimiwa, you have to join us. And you, the young people.
WHO,
tell us where to...
PPG, Honorable Justice, you're joining in the cutting. Ministry of Health, representative. And then whoever is representing LIRA. Who is representing LIRA? And for civil society, the representative from SEHAD, Madam Fatia.
Conscious about which color to put.
You put one that is universal.
Don't be oversensitive.
Okay.
You would have put green, you know? Even red. I'm really doing this on behalf of everybody who is up here. And we are appreciating the hard work that has been done to develop the knowledge base that all the activists need so that they continue winning the battles. But they are all doing this in the name of our people and for the people. So I would like to now launch the dissemination of this research for God and my country.
Okay, so before the dignitaries leave the podium, please stay behind. We'd like to get a group picture and then we can have the closing by His Excellency.
Don't stay away from me.
I didn't stay away from you. Please join us for the photo. Join us for the photo, those who can. You can even create 2 lines, maybe. Media people, maybe we create 2 lines. Some of these are the memories that one day we'll look back and say, we're aspiring for this, we have it. So we should always document our journeys. And we make sure we are on the right side of the story. Thank you very much. So we'll take our seats again and have the closing remarks. Remember, we have tea and coffee, and the drinks that are outside, those ones we're having, are the cocktail. I'd like to take the opportunity as we are closing to invite His Excellency, yes, Forst van Itro from the Royal Netherlands Embassy to give us the closing remarks. You're welcome, Your Excellency, and thank you for honoring our invitation and being with us throughout.
Thank you so much, moderator. Minister of Justice and Constitutional Affairs, Honorable Mao, Honorable Justice Tiberian, Honorable Members of Parliament, distinguished guests in all your different capacities, ladies and gentlemen, all protocol observed. Good evening, I should say by now, to all of you. It's an honor for me to address you here as we conclude this vital national colloquium on maternal and reproductive health and the law, hosted by Afia Nahaki. Honorable Minister, ladies and gentlemen, as we draw to a close, I am filled with a sense of urgency and optimism. Because today's discussions have been introspective, enlightening, passionate, and crucial for the future of Uganda, looking at what and how a holistic approach goes towards strengthening reproductive justice for women and girls. The examination of Uganda's demographic has shed more light on the pressing need to address maternal and reproductive health issues comprehensively. Ladies and gentlemen, as a nation with a youthful population, the decisions made here today will have profound implications for generations to come. Ensuring that women and girls have access to quality healthcare is not just a moral imperative, it's essential for sustainable development and prosperity, as we heard today. The role of the courts in advancing maternal and reproductive health cannot be overstated. We have seen how judicial decisions can protect and enhance rights, ensuring that every woman has access to the care she needs. The precedents set in Uganda's courts are beacons of hope, signaling that justice and health are inextricably linked. Honourable Minister, ladies and gentlemen, the Embassy of the Kingdom of the Netherlands supports initiatives in human rights and in sexual and reproductive health rights, which are in line with today's themes. Initiatives that work to uphold rights and secure health and well-being for all, using a multi-sectoral approach. In the health sector and more broadly towards a human capital development program, our support focuses on strengthening public and private health systems to provide quality health services accessible for all. In the justice sector, we support initiatives to both state and non-state actors that work to enable access to justice for the victims of gender-based violence in the formal and informal justice systems. Today we saw that Uganda's Demographic and Health Survey confirms Uganda is making progress towards improving maternal and reproductive health. For example, reducing maternal mortality, unmet need for family planning, and reduction of sexual and gender-based violence. And this progress is encouraging and reassures that with continued investments, Uganda remains on the right trajectory towards the SDG 3. We observe that progress varies by gender, age group and regions of the country, and wealth or urban and rural settings. It is impressive in some indicators, for instance, the maternal mortality, slow in some, like the reduction of unmet need for family planning, and very slow and stagnant, unfortunately, on others, like child marriage and teenage pregnancies. This challenges all on the agenda for health equality, for equity, further strengthening multi-sectoral approach, creating an enabling social, cultural and political environment that upholds sexual and reproductive health rights for women and girls. The discussions on the gender-based violence case management today have been both sobering and inspiring. The stories of resilience and the strategies for providing comprehensive support to survivors highlight the immense work being done and the work still needed. Effective GBV case management is crucial in breaking the cycle of violence and ensuring that survivors receive justice and the holistic support necessary for recovery. Advocacy plays a pivotal role in this journey, and the support to advocacy and the strategies we've discussed today showcase the power of collective voices in driving a policy change and societal transformation. Advocacy is the lifeblood of progress, pushing boundaries and challenging the status quo to ensure that every woman's rights are recognized and protected. So from here, I extend my deepest gratitude to Aria Nahaki and the facilitator for your passion and dedication, and for bringing us together for this colloquium. Your efforts are instrumental in driving forward the agenda for maternal and reproductive health and rights. To all speakers, panelists, participants, new minister, thank you for your insights, your passion and your dedication. Because together we are all building a foundation for a future where every woman and every girl can enjoy her rights to health, dignity and justice. Let us leave here today not just with ideas, but with the renewed commitment to action. The journey does not end with this colloquium, rather it begins anew with each of us as a champion for maternal and reproductive health and rights and the rule of law. So let us continue this crucial work with vigor and determination. Thank you.
Thank you very much, Your Excellency, for such an articulate and very impassioned closing remarks. We've come to the end of this colloquium, but not the idea of the colloquium. Because like you see, there's so many conversations we want to talk about that we need to talk about. Please feel free to share with us your views about what else you'd like us to talk about, because dialogue is something that we need to do very regularly, but also we deal in a space that is ever shifting. The space around maternal, reproductive health, access to justice is a space that there's always new things that are happening all the time. So we need to be up to speed to that. So please feel free to give us feedback. Feel free to suggest what else do you want us to talk about, because the topic is so big. And more importantly, continue being the high-level people that the minister talked about. He said he has not been in a space in Kampala and Greater Kampala, all the way to Entebbe, where. The space that has intelligentsia today is this space. Please continue doing the great work, because that means that you're doing work, but also it means that it is contributing to a collective. Now, when you look at your programs, do you still have them? There is page 3, and it has bullets in the expected outcomes. One of the bullets was to collaborate and network. Was that we are diverse, but there is one thing that we need to do to forge collaborations. And like we all know, the best deals in life are never sometimes done in the boardroom. They are done outside boardrooms. So I'd like to invite you to a networking cocktail, a networking tea. A lot is going to happen. We have the teas there. And then those of us that are like me, who after a certain hour do not take tea, also there are other things that are outside. Please do not leave, because Kampala traffic is maddening. Even if you leave now, we'll arrive at the same time as we'll leave later. And at the same time, we'd like to know you better beyond the person you're with around the table. With that, I'd like to bring this to an end, and thanking you all very much. Thank you for your time, and see you another time.